Right. Is everyone here? Shall we start? Akif, your first time joining?
Yeah.
Which year?
I'm in my fourth year.
Fourth year. Which university?
Dali Medical University.
Right, okay. Right. Okay. There's some familiar faces. Dulashi Ivanka. Which year?
Fourth year.
Fourth year. Which university?
DMU.
Right, okay. All Dalian. Huh? Okay. Right. So let's get started with today's topic, right? So for the new faces, I'm Prashan. Welcome to the Med Commute, right? Okay. So we are going to start this. Today's topic is ECG, right? ECG. Now, so electrocardiography, right? Electrocardiography. What do you all know about ECG, guys? Anything that you all know? Anything. Doesn't matter what it is, right? Anything. Come on, just unmute and talk, right? Have you all done an ECG on a patient before? Just give me a nod or give me a thumbs up or something. Done an ECG on a patient? No? Right. What is the ECG measuring, guys? What is our ECG measuring? What do you think? Come on. What is the ECG machine measuring? Guys, if there is any connection related issue, drop a message to our co-host. Right. Just let me know. What is the, okay. Heart's electrical rhythm. Someone, Adnan. Someone just unmute and talk. Don't be shy. You no need to, right? Okay. Just unmute and talk. Okay. Right. Okay. Correct. The heart's electrical activity. Now, what we need to know is, guys, the heart is driven by an intrinsic electrical impulse, right? We're going to see where this impulse is going to be starting, generating, how it's going to be transmitted, and how the contraction is occurring. We're going to talk about all of that, right? So, yes, you're correct. The ECG, basically, this is a machine that is drawing on a piece of paper, on a moving piece of paper, right? The impulse that it sees of the heart. That's all it's doing. Nothing complex, right? Okay. So before we dive deep into the ECG, let's go through some very basic concepts. Now, today's class is a little bit concept heavy, guys, right? But I assure you, it doesn't matter if you're in first year, doesn't matter if you're in the final, if you're an intern doctor, doesn't matter. Okay. If you stick through today, right, you will not need to memorize anything in ECG again, right? There's one location where you need to memorize a little bit. I will mention that when we come to that part. Apart from that, everything else about ECG is understanding. And the other important thing, now, even my final MBBS here, right? I got the Karapitia station. For my Viva, for my emergency medicine Viva, what I got was I walked in. There was a sir there, sir and a madam for pediatrics. The sir took out his phone and he's like, you get a patient coming in and you do an ECG. This is the ECG. They showed me an ECG. And that also, he didn't show me all the leads. He showed me only, if I can remember, I can't remember now properly. I think lead 2 or V3 or V4. He showed me one of that. So very important to know how to read ECG. Okay. Not just for your exam, even for your clinical practice. Luckily, I was fortunate enough to get the diagnosis. It was a VTAC. It was actually quite an easy case. But what I'm saying is, right, very important to understand how to go from diagnosing an ECG and how to manage, right? We'll talk about all of that. Right. So before we dive in any deeper, right, some basic concepts. First thing, overview of the electric circuit of the heart. Now, I have put some pictures, guys. You all just follow through with your note. I'm going to be drawing here. I've given you all the note. Just follow through with the diagrams on your note. You all can draw, write everything on that itself. Okay, right. So, overview of the electric circuit. Now, what I've done here is, guys, I've taken our complex heart diagram that we drew even in ischemic heart disease class, right? And I've simplified it here, right? So we've got this. I put the same diagram on your note. So we have the two atria and the two ventricles, and this middle green zone that I've drawn, guys. This zone is important. Now, this is where our atria and ventricles separate, right? Usually, we don't see it like a band like this in the heart. But why I have drawn it like this is where our valves are there, right? Our AV valves, atrioventricular valves, our semilunar valves, they're sort of in a line, right? So these valve cusps, these are fibrous structures, right? Fibrous structures, they do not conduct electricity, right? They do not conduct electricity. That's why I put it in a green sort of line, right? We'll see exactly from where to where electricity is being transmitted and how it goes. But just remember this fibrous, this green line, even in your diagrams, I've drawn it, that does not conduct electricity. That's the first one. Okay, right. So let's take a look, guys. We know, okay, just before we go any further, are there any first years here today? Any first years? Drop me a message. Any first years? Anyone? No first years, right? I'm hoping, right? I'm hoping no first years today. Okay, right. Any second years? Any second years? Drop a message. Drop a message in the chat. Yeah, I'm assuming no second years also. The third year and up, right? Okay, so you all know some basic stuff, right? So we'll go at that level today, right? Look at this, guys. We all know, right? The impulses of the heart, they begin here, right? At what we call the SA node, the sinoatrial node, the SA node, right? And from the sinoatrial node, guys, we have to get to this point. Here, there is another structure, another node, right? This is the AV node. Now, why do we call these nodes? There's nothing special, guys. It's just a bunch of specialized cells. We'll take a look at how these cells look, right? They are just a bunch of specialized cells. What is going to happen? Signals are going to start at the SA node. And here, guys, what I want you all to know, there will be some signals coming like this, right, in the atrium. And so that is for the right atrium, because our right atrium also needs some impulses. There are some other signals that are going this way to the left atrium, right? And then eventually they will make their way like this towards this AV node, right? So this is the atrium, how the atria are getting the impulse. Okay. Then after it comes to the AV node, it has to come now to the ventricles, to the ventricular system. So here we have, right, another bunch of cells called the bundle of His, right? This is again a group of cells. All of these structures are made up of tiny cells, right? So we have the bundle of His. From the bundle of His, guys, the bundle of His separates into a left and a right branch, right? A left and a right branch. And the left branch is something like this. And the right branch is something like this. Now, in the left branch, guys, there is actually a further division called the anterior fascicle and a posterior fascicle. For this basic, we will not go there, right? First, I want you all to understand the most basic concepts, right? So for now, no, SA node, onset of the impulse, coming to the AV node, it has to go through both the atria and come to the AV node. From the AV node, bundle of His, then it separates into the left and the right bundle branch and then goes to the rest of the ventricular myocardium. Okay, this is the basic transmission of impulses, right? Here, guys, the first point I want you all to know, this guy, this SA node, right? The SA node, it is capable of firing by itself. How? How does the SA node know that, okay, now I have to fire an impulse, right? This is a feature that it has, guys. We call it automaticity, right? SA node cells, they have a special feature. They can stimulate themselves and send things out, right? Now, don't laugh. Stimulate themselves as in electrically and then send impulses out. Okay, right? Okay. Then, so that is a feature. Automaticity is a feature of the SA node, right? Image? Okay, right. Then we go to AV node, right? We have to go through the atria, both the atria, and come to the AV node. At the AV node, guys, this is what we call the junctional area. This area, the AV nodal area, is called the junctional area. Junction, right? The junction. Now, at this junctional area, we said it is there within this fibrous ring, right? And with this fibrous ring. Therefore, guys, at the junction, at the AV node, the conduction of impulses is very, very, very slow. Okay, it is very, very slow. This is the next point I want you all to know. AV node, in this junction, nothing else conducts electricity. None of these fibrous structures. Only the AV node can conduct electricity. That conduction is also very, very slow. Very, very slow. Okay, right. Then we come to the bundle of His. The bundle of His. Bundle of His and the left and the right bundle branches. And this left and the right bundle branches, guys, as they come to the ventricular tissue, right, they give off tiny other branches like this. This is what we call the Purkinje system, right? We call it the Purkinje system, right? So this left and the right bundle branches, the bundle of His, and this entire Purkinje system, this guy is very, very rapid, very, very rapid in terms of impulse transmission, right? Okay, so just first I want you all to know the AV node, very, very slow, very, very slow. Bundle of His and the rest of the Purkinje system, very, very rapid, very, very rapid. Why is this? Why is this? This is the next question, right? Why is the AV node so slow? And why is the bundle of His and Purkinje system very fast, right? For that, guys, we have to take a look at this cellular structure, right? This is this cellular structure that I have drawn. Here is the AV node in blue, right? And this is the Purkinje system. Now I have drawn individual cells. This is a much, much more simplified version of it, but this is a basic diagram, right? Look at this, guys. What do we see here? If we take this blue structure, this is our AV node. In the AV node, you all can see cells are arranged like this, guys, right? This is the arrangement of cells, right? That's what I have drawn here, right? One thing, now what is the direction of current, guys? What is the direction of current here? Like this, right? Something like this. This is the direction of current, right? Everyone agrees? This is the direction of current. Now, what do we see here? One thing we see is, guys, the cells are arranged perpendicular to the direction of the current. perpendicular to the direction of the current. The other thing you can see here, these are very thin cells, guys. Look at the diameter. The diameter is very thin. These are very thin cells. Now, advanced level or ordinary level, grade 9, 10, physics. If you take an electric wire, right? Which wire has higher resistance, a thin wire or a thick wire? Which has higher resistance? Physics. Thin wires, right? The thinner the wire, higher the resistance. Higher the resistance, right? You all ever heard of Ohm's law and all of that, right? We talked about in school, right? I also don't remember to that extent now, but you all can recall something, right? So here, the same phenomenon, guys. The cells are very thin in diameter, right? Therefore, resistance is much higher. And the cells are arranged perpendicular to the direction of the current flow. Therefore, again, resistance is higher. Resistance is higher. This is why in the AV node, passage of current, impulse transmission is very, very slow. Very, very slow. Okay. Then when we come to the bundle of His and the Purkinje system, now that is what I've drawn here in black, the cells in the bundle of His and the Purkinje system, right? What do we see here, guys? What does the cell look like? The cell looks something like this, right? So what is this, right? If you look at the diameter, very large diameter, right? Very large diameter, right? Superior and inferior diameters. I'm talking about this diameter, with the vertical diameter. Vertical diameter is very large. And what do you see, guys? They are arranged parallel to the direction of current. The direction of current is this. Current has to go like this, right? This is how the current goes. The bundle of His and the Purkinje system, their cells are arranged parallel to the direction of the current, right? Therefore, what is it? So thicker, larger diameter and arranged parallel. Therefore, they are very rapid transmission. Very rapid transmission. Another important thing here, guys, if you take a closer look, if I take a zoomed in look, right, of two bundle of His and Purkinje system cells, right? This is what I've drawn here. If you see under a microscope, if you look, you can see a lot of tiny gate-like structures like this between two cells. What are these? These are what we call gap junctions. Gap junctions. So this bundle of His and Purkinje system between their cells, they have a large number of gap junctions. That is also going to help in the rapid transmission of impulse. We will see how the gap junctions play a role in a little bit. Okay. For now, this is what I want you all to understand. Right. So did everyone understand the overview of our heart's electric circuit? Give me a thumbs up. Right. Let me see. Right. Excellent. Excellent. Right. Just give me some thumbs up. Guys, turn your cameras on. Right. Okay. Right. Excellent. So let's go to the next part. Right. Let me erase this. Right. You all have all the diagrams in your notes. Right. Right. So guys, again, we have some new students who have joined after the initial intro. Are there any first years? No first years, right? Chamodya Satsarani, which year? Chamodya. 1, 2, 3, 4. 5. Okay, fine. Right. Okay. Right. Okay. The next thing we are going to look at is, guys, the cardiac electrical activity. Right. Here, what we are going to talk about is the impulse generation. We said under normal rhythms of the heart, the impulses begin at the SA node, and from there it goes to the AV node, right? And then from there to the rest of the heart, right? So now look at this, guys. When we start at the SA node, right? At the SA node, here what I want you all to know, there whatever impulses that begin at the SA node and is transmitted to the rest of the heart, right? These are called, right, sinus rhythms. These are called sinus rhythms. Okay, right? Impulse onset from the SA node, and from there it is transmitted to the rest of the heart. Those are sinus rhythms, right? So any deviation from these, now the sinus node, guys, sinus node fires impulses. We said it has a feature called automaticity. From that automaticity, it fires impulses at a rate of about 60 to 100 impulses. I'm still not talking about heartbeats. We are talking about 60 to 100 cardiac impulses, electrical signals, right? So the SA node fires at about 60 to 100 electrical impulses per minute, right? Then what is going to happen, guys? In this is the sinus rhythm within this rate. If there is anything that is going above or beyond this rate, we call it an arrhythmia, right? Arrhythmia. So what are the arrhythmias, guys? Right? There are mainly two types, right? What can happen? It can go either above 100, right? The firing rate can go above 100, or it can go below 60, right? So if it is going above 100, what do we call it? Tachyarrhythmias, right? If it is going below 60, what do we call it? Bradyarrhythmias, right? So we have tachyarrhythmias and bradyarrhythmias. These tachyarrhythmias, guys, now today we will talk a little bit later, right? It can further worsen and go to something we call flutter and something called fibrillation, right? We'll talk about those. Those are parts of tachyarrhythmia. Then when we talk about the bradyarrhythmias, there is also worsening conditions there as well, what we call heart blocks, right? Heart blocks. We'll talk about those also today, right? So this is the basic electrical activity that I want you to know, right? Then we'll go to a little bit of in-depth stuff. Now we are coming to the impulse transmission and the generation and the transmission, right? Let's take a look at how this is happening. Now, I have drawn, guys, 3 boxes, right? In your note, 3 green color boxes, right? With one in the middle nicely. So this is the same thing I'm going to draw here, right? Can you all see? No, that is good. Let me take a different marker. Right. Let me erase this heart also. We don't need it now. Right. Look at this. This is 1. These are, guys, cardiac myocytes. What I have drawn like this, these three are 3 cardiac myocytes, right? 3 cardiac myocytes. So there is A, cardiac myocyte A, B, and C. A, B, and C, right? If you want to call it, we call it ventricular myocytes, right? Ventricular myocytes. Now, let's start from the beginning. What is happening, guys? What I want you all to understand, right? We mentioned the word impulse several times. When it comes to muscle tissue, an impulse, what are we talking about when we mention an impulse? This is a positive charge coming in, right? What we mean when we say impulse generation and impulse transmission, we are talking about positive charge, right? Now, if we look at this cell A, this is the first guy, right? Let's say we are not going to discuss the mechanisms for A. We'll talk about B in depth. Let's say for A, okay. Now, this cell got a lot of positive charges, right? We don't know how. He just got a lot of positive charges, right? When a cell is full of positive charges, we say that cell has been depolarized, right? We say that cell has been depolarized. Why we say that? We'll see just in a moment, right? Now, what is going to happen is, guys, here between these cells also, we have these gap junctions, right? Between these are now cardiac myocytes. Now we are looking at ventricular myocytes, right? So what is happening? Cell A was depolarized. So that depolarization arrived, right, close to the cell B. And now what is going to happen? Some of these positive charges, guys, via this gap junction, they are going to be loaded, right? They are going to be loaded into this cell B, right? So some of the positive charges are coming here. These positive charges, guys, they are nothing else. I just want you to remember now, these are sodium ions, right? Sodium ions, right? Na+. Okay, yeah, I will draw that graph also. I've drawn it in your diagram so that we can go, right? So what has happened? Na+ has come from the previous cell that was depolarized. It has come through a gap junction into this cell, right? Okay, this is what we call, guys, cation loading. We call this cation loading, right? Because there was no specific signal to open this gap junction or something like that. This gap junction was always open. It's just that once the depolarization wave came to cell A, from cell A, this guy is going to transmit the sodium ions to cell B. And from cell B, we will see next towards the end, he will transmit to cell C. This is how depolarization waves go, right? Now look at this. Let's say, guys, this cell, this guy was nicely resting. He was nicely resting, right? At the resting state, guys, there is a membrane potential. What do we mean by a membrane potential? A certain voltage that this cell's membrane has, okay? During the resting stage, guys, this is about minus 90 millivolt, minus 90 millivolt. This is during the resting phase, Now what happens due to cation loading? Who is coming in? Sodium ions are coming in. When sodium ions come in, guys, what is going to happen? These are positive ions. So what is happening? From minus 90, this is going to go towards the positive aspect. The membrane potential is becoming more and more positive, right? So minus 90, minus 85, minus 80, like that, becoming more and more positive, right? Somewhere around minus 70, guys. Somewhere around minus 70, right? I will draw a dotted line like this, right? Something like that. Somewhere around minus 70, right? This cell reaches what we call the threshold potential. What is this threshold potential, guys? All of our body cells have a threshold potential. Our myocytes, they have a threshold potential. What is this threshold potential? Once this voltage is reached in a cell, in a myocyte, it is able to generate an impulse and do a contraction, right? That is what this threshold potential is. Until then, it is interesting, right? So what happened? Sodium ions due to cation loading, right? The potential of the membrane increased up to about minus 70. At minus 70, we are reaching the threshold potential. The moment this cell reaches minus 70 millivolts, which is the threshold potential, a special type of channels begin to open, guys, right? What is this? We call this fast-acting sodium channels. Right? This channel was closed, All this time it was closed. Now this guy opens. What is happening? from the fast acting sodium channels, guys, a massive number of sodium that was outside now starts coming in. So much of sodium, right? So much of sodium starts coming in, right? Okay. Everyone understood up to this point, right? Okay. Okay, good. Now tell me this. Okay, we were at minus 70. More sodium ions started coming in. Where should the rest of the membrane potential go? Should it go up or down? Should it go up or down? Come on, give me some answers. I want to make sure you all are not already dying. Okay, good. Image, good, excellent. Right? So we should go up. So exactly that, rapidly there will be a upward rise in the membrane potential. It will go so up, guys. It will pass even 0 and it will go to the positive side. Right? Let's say 0 was somewhere here. It will go beyond that also. It will go to about positive 30, up to about plus 30. It will increase. Okay, up to about plus 30. Right? Now, all right, let's say somewhere here. Right? Plus 30. It reached plus 30. Right? Plus 30. Now, before we go any further, this portion, guys, from here, from minus 70, from the resting membrane potential, up to this maximum amount of membrane voltage, right? Membrane potential. This is called the phase 0. Phase 0. What is this naming, guys? Why do we need this name? We need this name, guys, because we will see later we can correlate this to the ECG. So we know in phase 0 what is happening in the heart. Phase 1 what is happening in the heart. That's why they have put these names. Okay. So phase 0, when it comes to phase 0, this is done by what? Fast acting sodium channels. Phase 0 is done by fast acting sodium channels. Right? Okay. Understood? Right. Okay, I see you all writing. Okay. Right. Now this session, guys, we'll see, right? I'm still discussing. The students were asking about restreams. Right. I'm trying my best. Right. We'll see. Hopefully I will be able to get a positive response soon. Right. So yeah. So now what happens? Sodium ions came in. Rapid increase in the membrane potential up to about positive 30. Now what happens, guys, the moment it reaches this positive 30, this threshold, there is another type of ion channel that opens, right? I will draw that here, right? This ion channel, guys, this is our potassium ion channel, Potassium ion channel, what does it do, guys? It sends. Now, what do we want to do? Do we want to keep increasing this membrane potential plus 30, plus 40, plus 50? Do we want to keep increasing it? We don't want to do that, right? So our body's mechanism is that once it reaches this amount, this 30, that voltage will stimulate the opening of these potassium channels and it will start sending potassium out, right? It will start sending potassium out. What is happening the moment we start sending out some potassium, right? Here, guys, another thing I want to mention, the moment we reach plus 30, true, the potassium channels open, but the sodium channels immediately shut down. They immediately shut down, right? They immediately shut down when we reach plus 30. Okay. So now what is happening? Sodium channels shut down and then potassium channels open, potassium starts going out. If potassium starts going out, where should the deflection be from here onwards? Up or down? From this point that we stopped. We are going down. Good image. So we are losing potassium. So what is going to happen? There is going to be a downward deflection, right? We are going to see a downward trajectory. Now, why did I stop here without coming all the way down? Why, guys? Almost simultaneously as the potassium channels are opening, there is a third ion channel. I know this is now a lot of ion channels. These are the last doors, right? It's a third ion channel that opens, right? This guy is the calcium ion channel. Now, why do we need calcium to, now let's say, okay, calcium ion channel is open, calcium comes in. Why do we need calcium to come in, guys? Why do we need calcium into this myocyte? What is its function? Its function is to contract. So we need calcium to be brought into the myocyte to contract, correct? Right? So this is what is happening. Calcium is now coming in through this special channel, right? So at this point in time, guys, what do we see? Calcium ions coming in, potassium ions going out. Therefore, what do we see? We see a small flattening of the diagram, what we call the plateau phase. Here, guys, plateau phase is actually phase 2. So what was phase 1? Phase 1 was this tiny dip here. This tiny dip here. This was the phase 1. Right? Okay. So we have phase 0 going up. Then the tiny dip due to the potassium excretion. Almost simultaneously, what happens? Calcium ions start coming in. Therefore, there is a plateau phase. That is phase 2. Okay. Right? Okay. All good. You see some faces. Today is a little bit concept heavy, guys, right? Right? We'll see how it goes. I'll ask you all at a certain point if you all want a break, right? We'll see, right? Okay, right. So now we are phase 2, right? What is this? Plateau. What are we having here? Potassium going out, calcium coming in, right? At some point, guys, now you all know, for all of our muscles, we have an amount of calcium that we need. We don't want to overload our muscle cells with calcium now, right? For the contraction, there is a necessary amount of calcium. So once that necessary amount of calcium is reached, what will happen? This calcium ion channels will also close. However, potassium still remains open. So what is happening? If calcium ion channels close, potassium still remains open. What is happening? Potassium is effluxing out, going out. So the membrane will start, the potential will start dropping, right? The potential will start. This drop, we call it phase 3. Phase 3. Okay. Right? Right? Then guys, again, right? Now I have entered the diagram here. If you all have more space in this graph, just draw. Then again, it's reaching our resting membrane potential, which is minus 90. And then later again, another load of cations will come and the process will continue. It will go on, right? We don't need to talk about that. Now here, there are some important things for us to recognize. Look at this, guys. This phase 0, right? The phase 0 was what? Due to sodium ions coming in. Due to sodium ions coming in from the fast-acting sodium channels. What is another name for positive charges coming in? How do we call it? Depolarization. Depolarization, right? So this phase 0 is called sodium-dependent depolarization, right? Sodium-dependent depolarization. Then we have the plateau. And this phase 3 is what? This is what? Potassium ions going out, right? Positive charges going out. What is that? Repolarization. We are coming back to 90, right? The initial value was 90. We went up to 30. Now we are coming back. That's why we say repolarize, right? So coming back to 90 is repolarization. That is our phase 3. Okay. Here, there are some important points, guys. Look at this. From here, right? From here, look carefully. Yeah? From here, from about minus 70, when we were reaching up to the threshold potential, from that point up to about here, that is what? Halfway through our repolarization. From here to here, right? From here to here, at this time, guys, during this time, no other action potential can be initiated in this cell, right? During this time. Okay. Therefore, this period of time, we call it the absolute refractory period. Absolute, right? Nothing, no impulse can be generated. No impulse can be generated. Okay. Right. Then, here, guys, if I draw a straight line like this, right? Somewhere here, right? The straight line, I know my lines are a little off. This area under the graph, this bit, this point, this amount of time, right? Very tiny sliver, right? If you all have drawn the graph a little bit more slanted, maybe it will come nicely a little bit more, like this, right? Okay. So this tiny sliver of time, this is what we call the relative refractory period. Now, just like the name suggests, what do you think? Relative refractory period, guys, during this time, sometimes in certain pathologies, there can be a new impulse being generated. But, right, for the majority of the time, under normal circumstances, again, this is also refractory. That means no impulse can be generated. Certain times, that's why we put the word relative. In certain times, some impulses can be generated. Right? Okay. Here, guys, now in the absolute refractory period, right? In the absolute refractory period, why do you think no more action potentials can be generated? Why do you think? Why do you all think? Come on. Unmute, right? Give me some hypothesis, right? Taimur is here. Come on. Unmute and talk, right? During this time, the absolute refractory period, based on, okay, let's just imagine these channels, guys. Take a look at these channels. Based on these channels, what do you think has to happen for a new impulse to not be generated from these channels? What should happen to some of these or one of these channels? What do you all think? Come on. Unmute and talk. Let me ask someone. Let's see. Dulashi. Dulashi Tivanka, yeah? Dulashi, what do you think? Guys, there are no wrong answers here, okay? No one's judging you for anything. I want you all to think and make hypotheses. I want you all to come up with things, even if it's not possible. Come up with things and try and tell me. That is the type of thinking I want you all to have. Now tell me this, guys. If I ask you for the generation of action potential, for the generation of impulses within this cell, out of these three channels, for the generation of impulse, not for contraction of muscle, for generation of impulse. Out of these three channels, which channel do you think is most important? Channel number 1, 2, or 3? What do you think? Come on. Give me a 1, 2, 3 on the camera. Huh? Oh, come on. Imesh, what do you think? 1, 2, or 3? 1. Good. Anyone else want to challenge? Okay, someone just unmute and talk, because guys, I can't keep reading the chat box. It's difficult to focus. Just unmute and talk. Don't be shy, right? Okay, Lula, right? Do you want to challenge Imesh? Huh? You agree with Imesh? Channel number 1 is the most important? What do you, yes or no? Give me a nod, yes or no? No. Okay, so 2. Okay, so Imesh, right? She's challenging your answer. Right. Okay, good. Lula, do you want to explain why? Do you want to explain why? No? Okay, it's okay. Right, look at this, guys. So I agree with Imesh. Okay, right? Here's the thing, guys. What was the channel that was required to take the membrane potential from the threshold upwards? That is our fast-acting sodium. If our fast-acting sodium channels are not functioning, guys, the potential will remain at this threshold, right? A little bit more it might rise based on the amount of sodiums that come during theta ion loading. However, there is not that much of sodium enough to raise this all the way to positive 30 coming from this cell. Okay, there is only a little bit amount of sodium that is coming in to take the potential from -90 to -70. Beyond that, we need these fast-acting sodium channels to open and suck in sodium, right? So this sodium ion channel is the most important, we would say. Now, why during absolute refractory period, there is no more impulse generation is during this time, guys, soon after this guy's job, right? We said, right, once it reaches +30, what is going to happen? These guys are going to be close shut, no matter how strong an impulse comes. These guys won't open. They will not budge, right? They will not budge. Okay, right? So because of that, sodium ion channels are being shut closed. Therefore, that is why we get an absolute refractory period there, right? Now, did everyone understand up to this? Right? Come on, give me a thumbs up. Give me a thumbs up. Be active, right? Okay. The next time I'm going to tell, if you all have understood, stand up. That's what I'm going to say next, because I see some faces like this, some like this. Okay, right? Okay, look at this. Be active, right? Now look here, guys. What happened? Potassium went out. Fine, potassium is out. But we have a lot of sodium built up within the cell. And we have some calcium also built up within the cell. What is going to happen to the calcium? Calcium will be taken for the contraction purposes, right? You all know from this sarcoplasmic rate. That's a physiology class. We'll talk about that some other day. Muscle contraction, cerebral muscle contraction, cardiac muscle contraction. We'll talk about those some other day, right? But what is going to happen? This calcium is going to be utilized, right? And any remainder will be recycled. We don't need to talk about that. So calcium also fine. That is also gone. Potassium definitely gone. This sodium, there is a lot of sodium now that has built up in this cell. Before the next impulse comes, what should happen to this sodium? He will use gap junctions to the next cell and go, right? Sodium will be brought to this cell. Okay, via cation loading, right? Cation loading. Did everyone understand? Right? Therefore, what is happening, guys? After this entire action potential is generated, there is no excess of sodium ions or anything that has been sent to the next cell. What do we see here, guys? Depolarization happened. First cell A, from cell A, cell B was depolarized. From cell B, cell C was depolarized. What does this tell you? Depolarization, like a wave, spreads from one cell to the other, right? Spreads from one cell to the other, right? Okay. Right. The next thing I want you all to know here is, guys, just remember, keep in your mind, repolarization. What is repolarization? Positive ions going out. That one is mainly done by potassium ions, right? Potassium ions. Do not forget that. It will come in handy when we go further. Okay. Right. What is the other thing I want you all to know here? Look at this, guys. The calcium ion channel. The calcium ion channel was the last to open, right? This guy was the last to open here and bring in the calcium, right? Before that, initially there was cation loading, sodium came in, potassium went out, and finally only this guy opened. What does this tell you? There is electrical activity happening first, right? Followed by calcium coming in, and what will calcium do? Contraction. Contraction is what? Mechanical activity. Always in the heart, electrical activity is first, and it is followed by mechanical activity. That is the next point I want you all to know, right? First electrical, followed by mechanical activity, right? Okay. Is everyone clear about up to this point? Right? Give me a thumbs up. Come on. Right. Good. Right? Take this step by step, guys. Right? Don't worry. ECG is One of my favorite lessons to teach. Right? Okay, let's go. Next thing. Now, what did we see? We talked about the impulse generation, how it is being transmitted from cell to cell. We have discussed all of that. Now we'll come to measuring this. Measuring these impulses that are, can you all see me? So on focus, right? Right. Now we'll talk about measuring this electrical activity. What are we going to do, guys? This is where the standard ECG comes. What is the standard ECG, guys? A standard ECG. Standard ECG is a 12-lead ECG, right? There are 12 leads. There are 12 leads, right? So what are these 12 leads? Now we have talked about this in the ischemic heart disease chapter also, right? The 12 leads are, we have 6 limb leads, 6 limb and 6 chest, right? These are our standard ones. These are standard 12-lead ECG, right? These limb leads actually, guys, there are, we have talked about this before. So there are 3 real ones, 3 real and 3 augmented. What is this augmented? We'll take a look, right? What are these 3 real leads, guys? You all know there is 1, 2, and 3. Right? If we take the heart like this, right? Something like this, right? Lead 1, lead 2, and lead 3. These are actual leads, right? We place these on the patient. These are actual leads. Then, based on the impulses that are generated with it, for these leads, we take vector sums, right? Now, you all have done vector sums in maths and in physics in school, right? So we take vector sums, right, to come up with what we call these augmented leads, right? So for example, with from 2 and 3, we get an augmented one here. We call it AVF for the foot, right? Foot, AVF. Then here we get another vector sum. This is AVL. And here we get another vector sum, AVR, right? Okay, so these 3 are augmented. That's why you put the A, right? Augmented, 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 right? F, L, and R. Okay, right? Right. Then guys, now what I want you all to know here is these limb leads. The limb leads are looking at the heart in the frontal plane, right? What do I mean by the frontal plane? If I take, do I have, it's okay. Imagine the heart being like a globe. Imagine the heart being like a globe. Imagine you're cutting the globe from the middle, from top to bottom, right? That is our frontal. That is a frontal section, right? So these leads are looking at the heart from the frontal plane. Okay, from the frontal plane. Then we have the chest leads, guys. The chest leads, if you take a look at the chest leads, right? If I draw the heart something like this, they are looking at the heart. If I draw a person, right? Is the neck and the right? Something like this. They are looking at the heart, guys, from a horizontal cross section like this, right? So imagine you draw like something like that, right? Like a cross section of the heart, something like this. And we are looking at, there are multiple leads, right? We'll talk about, right? There's V1, right? V2, right? V3, there's 6, V4, V5, and finally V6, V6. Okay. These are looking at this horizontal view of the heart, the horizontal section of the heart, right? Now, here, guys, now this was the standard, no? This is a standard 12 lead ECG. There are some extra leads that also we need to talk about, right? What I mean by these extra leads, guys, especially the chest ones, we have 3 posterior leads. Now, these ones are looking at the anterior and the left side of the heart. There are some that are looking at the posterior aspect of the heart, right? There's a V7, there's a V8, and a V9. Now, these ones, we don't always use. Only sometimes we will use it on the patient, right? If we are suspecting a posterior MI, we can use it, right? Then, there is another set of leads, guys, right? Again, chest leads, somewhere here, right? Look at this, like this. Now, majority of our standard leads, these are looking at the anterior and the left lateral direction. There is no one to look at the right, right? So these are some extra leads that we have that can look at specifically at the right heart as well, right? So here we have, right, a V3R, V3R, V4R, right? It's the same V3, V4, V5, right? V3, V4, V5, but we put a R to denote that it's on the right side, right? So we have V3R, V4R, and V5R. Those we can place on the right side of the patient, on the right side, right? Generally, we place the ECG on the left, okay? Right. Now, we've discussed this part in the ischemic heart disease also. You all, I suggest if you all haven't watched it, go, it's on YouTube. Huh? You can watch that later when you all have some free time. Here, what did we say, guys? In the ischemic heart disease chapter, we talked about V1 to V4. Leads V1 to V4. Usually, we call them anteroseptal leads, right? Anteroseptal leads. If you all want to be more specific, guys, usually we say V1 and V2, right? V1 and V2, and then we say V3 and V4. V1 and V2, we say they mainly look at if you take the atrial septum, the ventricular septum, right? We further divide the ventricular septum into the left and the right septum, right? Right septum. So this V1 and V2, we say they generally look at the right septum, right? And V3 and V4, we say they look at the left side of the septum. However, both are, all four are anteroseptal leads, right? Then we have V5, V6, which are looking at the lateral aspect. Okay, right? So we've talked about this. They are also in depth, right? You all can go through that. Now, is everyone clear up to this point? Right? Okay, right. When we place the ECG leads properly on a patient like this, right? The standard 12 lead ECG, we are going to get a pattern on the ECG paper like this, right? So now we have to understand how is the ECG machine drawing this. That is where we come to the physics of the ECG machine, right? Look at this, guys. What is happening inside the ECG machine and how is it drawing this pattern, right? Look at this. Firstly, now I have put some, I put like a table on your note, guys, with some diagrams. Let me show you, right? I have drawn like a piece of, like a thing like this, right? And like this, right? Something like this I've drawn on your diagrams, right? I hope you all can see. What is this, guys? Right? This is a thin slice of myocardium, right? What I have taken is a thin slice of myocardium. Let me draw it in the middle. I need the space, right? You all can use those diagrams. You all don't need to draw this again. So there is a thin slice of myocardium here. Look at this, right? Right? Okay. And to this thin slice of myocardium, guys, we have attached two electrodes, right? One electrode here, another one on this end, right? And those two, right, via a wire, they are connected to a certain device, what we call a voltmeter, right? This is connected to a voltmeter. Now, what does a voltmeter do? It has a needle. It has a needle in the middle, right? And it will deflect based on the voltage that this is reading, right? What is voltage, guys? Potential difference across 2 points, right? Physics, right? Okay, have to have some physics knowledge also, right? Okay, right? Now, look at this. Let's say, I will say this is a negative electrode and this is a positive electrode. Okay, negative electrode and a positive electrode. And in the voltmeter, let's say this middle here is 0 volts, no voltage, okay, no voltage. And here, if there is an upward movement, this is moving towards the positive. If there is a downward movement, this is moving towards the negative. I'll explain what is that, okay? Now look at this, guys. Let's say I have this thin slice of myocardium that I've freshly cut from a person, right? Let's say this piece of myocardium was resting, right? I will call this point A and point B. If this piece of myocardium is resting, guys, okay, is there a difference in voltage in point A versus point B? Is there a difference in voltage? The entire myocardium is resting. Is there a difference in voltage? There is no difference in voltage, right? If there is no difference in voltage, this guy will stay in the middle at 0 because there is no potential difference being measured, right? Everyone agrees, right? This guy will stay in the middle. Okay. Now, then let's imagine, now that is your first diagram. Now you all can move on to the second one, the next row in the table, right? So no potential difference. Piece of myocardium is resting, right? Right. Now let's imagine, let's take this up a notch. Let's say I am stimulating this A end, the cells in the A end. I am depolarizing them, right? Okay. You all know, guys, cardiac myocytes. Now each of these are a myocyte, right? You all know cardiac myocytes, the moment they are depolarized, when one muscle is depolarized, what did we see? Via the gap junctions, after the entire depolarization and everything is complete, what will he do next? Transmit the depolarization to the next cell. From there to the next cell. So what is going to happen? From here, there is going to be a depolarization wave that starts, right? Okay. So you stimulated point A, but there's going to be a depolarization wave that's starting out, right? Because of this, what is happening? A positive wave, positive charges are moving towards the positive electrode, right? Positive charges are moving, these are positive electrodes, are moving towards the positive electrode, right? When there is positive charges moving towards the positive electrode, what happens, guys? This needle deflects towards the positive, right? This needle will move up. Okay, right? It's basic physics. I'm making it as easy as possible, right? Okay. If you all have done advanced level or ordinary level, right, you should understand, right? Okay, right. Did everyone get that point? Right? Okay, right. So that is our second, that's your second one, right? So now just tell me here, guys, if I draw, I think I have left one column saying vector. Right? So in the vector one, in the first diagram, was there any vector generated? No vector. You can leave that blank. Here there is a vector, guys. What is the vector like? Right? Something like this. You all can draw. It's a positive vector. And it is directed in this direction. Okay, you all know vectors, they have a direction as well as a, what do they have? Vectors have a direction and a, vectors have direction as well as a value. No, I forgot what the term is there, right? I was having a little bit of a brain fog, right? Vectors have magnitude. Yeah, they have a direction and a magnitude. Yeah, there we go, right? Okay, right, okay. So that is the second scenario. Now, let's take it up a notch again, the third diagram, right? I will erase this a little bit. For the third diagram, guys, what I have done, I have taken a thicker piece of myocardium, right? Thicker piece of myocardium, right? Okay, like this. And what am I doing? I am doing the same thing. I am stimulating this entire A line of cells, all of these. So what is going to happen? Again, impulses will be transmitted. But now tell me this. When there is a thicker myocardium, we have more cells on this A end. Everyone agrees, right? There are more cells. If there are more cells, what do we have? More gap junctions, more sodium ion channels, right? So what do you think, guys? There is going to be a large vector. There is going to be a large deflection when these positive charges are moving towards the positive electrode, right? This is going to be a very large deflection, and it is going to be a rapid deflection as well. So like this, right? Something like this, right? Very large, very large. If you are drawing the vector, draw it like this. This is the size of the vector, and it's a positive vector. Okay, so there is a size difference in the vector, magnitude difference, right? And the positive charge is there. Okay, that is the vector when we have a thicker myocardium. Now, why is this important to understand, right? What is the thicker portion in our heart? The ventricle. The ventricle. So you always see, guys, when the ventricle is contracting, the ECG machine, right? Later we'll talk about the ECG machine. This is just a voltmeter we are talking about. This is not the ECG machine. In the ECG machine also, the ventricular vectors are usually large. Therefore, they will detect those over other vectors, right? We'll see what I mean by that. Okay, right? Right. Then we'll take it one more step. Let me erase this. And you all can go to the next diagram. Again, back to our thin, right? Thin stuff, something like this. And let me erase these. Right? Now, the next scenario. Let's say, yeah, there we go. Right? Let's say, now, in the next scenario, I am stimulating point B. I am stimulating the cells in point B. Right? I'm stimulating these cells, point B. So I'm giving a wave of depolarization starting at point B. What is going to happen? As usual, they are going to, via their gap junctions, stimulate the next cell, right? And a wave of depolarization will go towards A. Now what is happening, guys? Positive charges are going away from the positive electrode. Everyone agrees? Positive charges going away from the positive electrode, right? If positive charges are going away from the positive electrode, guys, what is going to happen? We are going to get a negative deflection. This is going to go down, right? This is going to go down. Okay, right? Everyone agreed? Right? The positive charges going away from the positive electrode, right? Okay. Then let's take this again, the next scenario, right? Okay. Right. Look at this. Next scenario, guys. Now I'm telling you, remember, guys, in our cell, in our cardiac myocyte, when we were drawing the action potential, there, what did we see? After 70, sodium channels will, after minus 70, fast acting sodium channels open and a rapid influx of sodium. Therefore, what happened? Membrane potential increase up to about positive 30, right? When it's at positive 30, guys, that cell is fully depolarized. We say that cell is fully depolarized. It's full of positive ions. Now let's imagine this cell is also like that, fully depolarized cell. What do I mean by that? Right? Fully depolarized, has a lot, entire cell is full of positive ions, right? If that is the case, now tell me this, is there any potential difference across these two legs between point A and B? Is there a potential difference? There is no potential difference. What will the voltmeter read it as? The voltmeter will read it as 0, right? He will remain in the 0 state. So now we have seen two conditions where the voltmeter is showing no reading. The voltmeter is showing it as 0. What was the thing? Initially, when there is no depolarization at all, when the cell is resting. The other thing is when the cell is fully depolarized also, we are getting a 0 volt reading. Okay, everyone agreed, right? Okay, right. So again, the vector here, nothing, huh? No vector generated. Okay, so you all can leave that as a blank space, right? Then next one, look at this. Let me draw this again. Right. Okay. The next scenario, guys. Now let's say Now I will tell you all by some mechanism, right? I have some magical power, right? I have some magical power. And what I'm doing is I am able to make this Bn negatively charged, right? Negatively charged. Now, all this time we were talking about positive charge, depolarization. Let's say I am able to make this Bn negatively charged. How I do that? I go and stimulate the potassium ion channels in this Bn. Then what is happening? Potassium starts effluxing out, right? So because of that, these cells become more and more and more negative. Now these cells are negative, right? Okay. Now, how I'm going to tell you guys, when I make this end negative, right? When the potassium ion channels of these cells are opened and the potassium started leaking out and they became more negative, they will affect the next cell to do the same thing, right? They will affect the next cell to do the same thing. What do I mean by that? The next cells, potassium ion channels also open. Next cell groups, potassium ion channels open. They start losing potassium. From there, the next cell. So all of this becomes negative, like that. So what are we seeing here, guys? Negative charges, right? Are moving away from the positive, or in another way we can say it, are moving towards the negative electrode, right? A negativity, right, is moving towards the negative electrode. Now, how did this negative charge come, guys? The negative charge came via the loss of positive ions, via the loss of potassium ions, right? Specifically, right? Potassium ions were lost, therefore they became more negative, and that affects the next group of cells and the next group of cells. Same mechanism. So what is happening? Negativity coming towards the negative electrode. What do you think the deflection will be? Up towards the positive or down towards the negative? What do you all think? Come on, show me up or down, up or down. Come on. Yes, it's okay. No mistakes here, right? Let me see some faces. 5 more. Come on. Right. Come on. Imesh, up or down? Up. Okay, good. Right? Good. Right? Right? Here, guys, it is an upward deflection. Right? Now, this is physics. This is physics. I cannot teach this more than this. Right? Okay. Right? My physics knowledge is not that good. Right? Actually pretty poor. Right? Okay. Anyways, so this is what is happening. Bio students, guys, we are bad at maths anyway, right? Okay. Right? So when there's negative charge going towards a negative electrode, we get a positive deflection in the voltmeter. Right? Okay. Then just, right. Did everyone understand up to here? Right. Then just one more point to mention, guys. Let me draw this again. The last one. Let's say something like this. The same one, Same diagram. Slight difference. If I say, now this is a thin piece of myocardium again. I'm saying this middle line of cells, like this line of cells. I'm saying this line of cells is a specialized group of cells, right? A specialized group of cells, something like this. They look a little bit different, right? And I'm telling you all, right? I am depolarizing this A end. I'm depolarizing this A end, right? And because it is a modified group of cells, there is a very rapid transmission, right? There is a very rapid transmission coming to the B end, right? Of the depolarization, right? Very rapid transmission of the depolarization wave coming to the B end, right? How will you see it here, guys? In the voltmeter, how will you see the deflection? The deflection, guys, it will be the same in terms of vector. In terms of vector size, it will be the same as our previous diagram, right? But what I want to mention is this deflection will be very, very fast, right? The deflection will be like this, very fast. Whereas the previous ones, it was a tiny deflection. So, right, if I'm drawing it, it's a tiny deflection. This one is a rapid deflection, right? Rapid deflection. Okay, right? Just know that difference. We'll see why that is important when it comes to ECG. Okay, right? So, if I'm asking you, this specialized group of cells here, what was I thinking about? I was thinking about the Purkinje system, Purkinje system, right? Anyway, right? Is everyone clear about this basic concept, physics? All good. So here, what do I want you all to keep in mind as we go through the next bit of our lecture? Whenever positive charges are moving towards a positive electrode, it's an upward deflection, right? It's a positive deflection, upward. Whenever positive charges are moving towards a negative electrode, it is a downward deflection, right? And then if it's a thicker piece of myocardium, we get a large vector, right? These points I want you all to remember as we move on, okay? Right. With that knowledge, guys, we will come to impulse vectors of the heart. Impulse vectors, right? Of the heart, right? Impulse vectors of the heart, right? Now, you all must be wondering, where is ECG? Still no ECG. Trust me, guys, right? When the study of ECG is just barely the clinical things that you need to know. The rest of ECG is all in the waveform. If you don't understand waveform, very difficult to diagnose, right? You will never get textbook ECG patients coming in. But if you understand the physics behind it, very easy. Okay? So that's why I'm taking this time for you all. Okay? Don't worry, we'll get there. Right? So impulse vectors of the heart. What are we looking at? Look at this, guys. I have drawn this diagram again for you all. Right? You all don't need to draw it. Right? Our same diagram as before. Right? Here. If we look at the vector directions of the heart, what do I mean by that? So we have the SA node, the AV node, and so here the atria and the ventricles. Here, guys, what did we say? Right? Initially, from the SA node, there are impulses going both these ways. One for the right atrium, one for the left atrium. Right? So the overall vector direction will be something like this. This is the overall vector direction. The first one. So this is the in atria, right? In the atria, the vector direction, guys. If I draw this if you all imagine this as a straight plane, the vector direction is in the atria, downward, and to the left. Downward and to the left. This is the vector direction, right? This is what I have drawn, right? Downward and to the left. Okay. Right. Then from there, we come to the AV node. AV node. Look at this, guys. What is the vector in the AV node? Now tell me. What is the vector direction in the AV node? Come on. Guys, unmute and talk. Very difficult otherwise, right? Taimur, come on. What is the vector direction in the AV node? What do you all think? What was the special feature we mentioned about the AV node at the start, guys? What did we say about the AV node? Samodya, come on. What did we say about the AV node and its transmission? Come on, unmute. Talk, guys. Don't be shy. Manari. Chatuni, let's go. Come on. AV node. What did we say at the start? Lula? Yeah.
I guess the cells are perpendicular, so
right,
the transmission is slower.
Very slow, right?
There is high resistance.
Excellent. If that is the case, excellent. Thank you. If that is the case, do you think the ECG machine will see it as any voltage being transmitted? No, right? Here, guys, the ECG within the AV node, the ECG machine does not detect any activity, right? So therefore, we do not see a vector here. What we do see, we call it the AV delay, right? Now, don't worry. This term, I will explain it again when we go to the ECG, right? We see something called an AV delay, right? Then coming to the ventricle. Look at this, guys. Ventricle is very important. If I draw the septum, I will draw the septum and the ventricular muscle, right? This is now, this area, this zone is the ventricular muscle. All of this is the ventricular muscle. Look at this, guys. Coming to the ventricle, right? We said there is always, right, the bundle of His, the left and the right bundle branches, and the Purkinje system. This is the structure now. Here, what do I want you all to know initially, guys? Look at this. We'll take it step by step. But now I want you all to know, when it comes to the ventricle, the ventricular depolarization is divided into three, right? What do I mean by that? If I take ventricle, right, it's divided into three. First, what happens first is what we call septal ventricular depolarization. The septum, right? Septal ventricular depolarization. The septum has to first get depolarized, right? The septum. Then we have the major ventricular depolarization. Major ventricular depolarization is the next step, right? Then the final one is the third one. This is basal ventricular depolarization. What do I mean by this, guys? Look at this. Septal ventricular depolarization. Depolarization of this septum region, right? Depolarization of the septum, guys, always under normal physiological conditions in you and I always happens from left to the right, from left to the right, from left to the right. Okay. This is how the septum is always depolarized. Now, what do I mean by from left to the right? If I take this septum portion here, it is full of cells now, guys. It is full of cells like this. The septum is also full of cells, right? So always what happens in the ventricular septum, guys, first this left-sided cells get depolarized and then they transmit it towards the right. They transmit it towards the right. This is what is happening within the septum. right? Always left to the right, always left to the right, right? Here, guys, actually, if you see, now I have drawn this like a curved arrow slightly, right? This is to the right and slightly upwards also, right? So the overall vector direction is slightly upwards and to the right, right? So you all can write down the vector direction upwards and to the right, upwards and to the right, okay? The septal ventricular depolarization, right? Then the next one, major ventricular depolarization. What is this? Major portion of the ventricle is now going to get depolarized. That is in this direction. Okay, that is in this direction. Don't worry, we'll go into depth. This is just still we are starting out. In major ventricular depolarization, what is the vector direction? Downwards and to the left. Downwards and to the left. So you all can write that. So major ventricular depolarization is downwards and to the left. Okay. Then, guys, now what has happened? The septum and this bottom portion is depolarized, right? The septum and the bottom stuff is done. What about this stuff? What about this stuff? They also have to get depolarized. So then, guys, after that, there will be depolarization waves going in these directions, right? Okay. These areas, these thinner areas, these are what we call base, right? We call them the basal ventricular depolarization. The basal ventricular depolarization, again, you all can write upwards. You all can just write it upwards. It doesn't generally have a direction. If you all want, you all can say upwards and to the slightly to the right, but not really, right? Just upwards is enough, right? Okay. So basal ventricular depolarization is like that, right? Okay. Then, guys, one more important concept before we go on. If I take the heart, right? Heart is like this now, guys. What I want you all to understand, in the heart, depolarization waves, right? Depolarization waves, it starts at the SA node, and then is spread across the heart, guys, like this, in this fashion. This is how depolarization waves are spread, right? What is this fashion? Inwards to outwards, inwards to outwards. This is how depolarization waves go in the heart. Whereas, if we check repolarization, what is repolarization? Loss of potassium. If we take a look at repolarization waves, guys, they are spreading like this. What is repolarization? Negativity. How is negativity spreading in the heart, guys? From outside to inside. Now, you all might have also had some bad friends who are spreading negativity to you, right? Always negativity comes from outside, no, guys, right? Right? We are trying to be positive. We are trying to help others, but negativity comes from outside, right? And engulfs us also. Same thing here, right? Repolarization waves are coming in an outward to inward fashion, right? You all will see why this concept is important, right? But now if you understand that is so. Now I said what? Depolarization from inwards to outwards and repolarization from outwards to inwards, right? If I say that, now listen carefully. Use all layers of your cerebral cortex. If I say here, there is a cell, there is a cardiac myocyte, right? Let's say cell A. Let me draw 3 cells here. Let's say A, B, and C, right? Let me put this A, B, and C, right? Okay, 3 cells in the cardiac wall. Now, if I'm saying depolarization is happening from an inward to outward fashion, which cell out of this A, B, and C is the first to get depolarized? Come on, A, B, or C? Which is the first to get depolarized? Guys, come on. Huh? A, B, or C?
A.
A, right, excellent. A is the first to get depolarized and C is the last to get depolarized, right? Now, the same 3 cells, if we are looking at the repolarization, for the same 3 cells, A, B, and C, which guy is the first to get repolarized? Which guy? Which cell? C. Excellent. C, right? So what do you see here, guys? What is the principle here? In the heart, in cardiac myocytes, right? The last group of cells to get depolarized are the first to start repolarizing. This is important to understand because you all will see when we are drawing the ECG pattern, right? You all should understand that the last cell that got depolarized is the first to start repolarizing, right? So this is how it happens in the cardiac cycle, guys. First depolarization spreads like this, then repolarized again. Depolarization, repolarized, right? That is how it is happening in our heart, okay? You all will understand why that concept is important, okay? Is everything clear up to this point? Right? I'm going as slow as I can today, right? Give me a thumbs up. Is everything clear? Right? Okay, excellent. Right? Good. Time out, all good? Okay, excellent. Right. Then let's move on. Right? With that understanding, now we can go to the next step. Right? Look at this, guys. Now we have seen the atria getting depolarized. We have seen the ventricle, how it's getting depolarized in three stages. So before we go on any further, we can just name this for now, right? What do I mean by name this? This first wave is called the P wave. P wave. This signifies atrial depolarization. Don't worry, we are going into depth. Now I'm just telling you all the names, right? Then here you all can see a small straight line. What is this straight line, guys? This is our AV nodal delay. This is our AV nodal delay. We call this a PR segment. Now, remember, there is another part called the PR interval, right? I will teach that later. For now, just know this is called the PR segment, and this represents the AV nodal delay. We said during the AV nodal delay, the ECG won't detect anything. So it's a flat line. It's a flat line, right? Okay. Then here, there's this here, right? Actually, there is a small dip here, right? I haven't drawn it properly. There's a small dip there. Right? That is our Q wave, right? And here is the R, and here is the S. This Q, R, and S, guys, it corresponds to the three stages of our ventricular depolarization. What were the three stages? Septal ventricular depolarization, major ventricular depolarization, and basal ventricular depolarization. Okay? Septal, major, basal. Okay? Right? Then, guys, here there is another flat wave. I will teach that in a while. Here there is another wave, what we call the T wave. The T wave. What is this T wave? This is our repolarization. Repolarization. We will see why these are happening like this. Okay. For now, just know the names of the waves. Right. Right. So we'll come to understanding the waveform. Look at this, guys. Now what are we going to do? That same, remember our same thin slice of meat? Like that, we are going to apply that principle to a live human being. Look at this, guys. I have drawn there's a nice, there's a picture of I think a girl in your note. And we have connected two electrodes to her. Right. We have connected two electrodes. Right. And from there, right, again, the same thing, right? We get like that. And this time, right, we are connecting this not to a voltmeter. We are connecting her to a ECG machine, right? The ECG machine, guys, right, it is also somewhat like a voltmeter. What I want you all to imagine, let's first draw the similar to the voltmeter. Now here, instead of a needle, there is, let's imagine like a pen with a tip, right? There's a pen with a pen tip here, right? This part, we don't need it actually. There's a pen with a pen tip, right? And what is happening, guys, here, just beneath this pen tip is a roll of paper, right? A roll of paper. And this roll of paper, right, it is connected to a motor here and it is rolling. It is rotating. So while it's rotating, what is happening? Paper is moving. The paper is moving, right? So what is happening? This pen tip is going to draw on this paper, right, as it moves out. As it is moving out, it's going to draw various patterns that it is seeing. Okay? So this is what is happening inside the ECG machine, right? Now, if we take a look at this, if we take a look at our, that's a picture of a girl there, right? We have connected her here on the right arm to a negative electrode, right? And here on the left leg to a positive electrode, right? Now, look at this, guys. We are going to focus on the lead placed here and how it is going to see this changes in the heart. Here, guys, if I draw the heart, it's something like this. Draw the heart like that. Yeah, something like that. Okay. Now, using these electrodes, it is going to detect the potential difference and the differences in electric fields in this heart's myocardium. Okay. Right. Let's take a look. Firstly, right. I will start here. You all have space in your diagrams. Huh? If we consider the atrium, in the atrium, what was the direction of the vector? Come on. Tell me. Now this part will be a little bit interactive. Otherwise, you all are going to sleep now. Huh? What was the direction of the vector in the atrium? Huh? Guys, come on. Unmute. Huh? Who is here? Shiza. Dinita is here today. Dinita, unmute. Come on. Manari. What is the direction of the vector in the atrium? Lula. Come on. Yeah, downwards and to the left. We discussed this, right? Downwards and to the left. So if the direction, now imagine, now this is drawing, right? Let's first imagine there is no current at all. What will it draw? It will just stay in that midline as the paper moves and it will draw a straight line. Everyone agrees with that? No? That is what we call the baseline, guys, or the isoelectric line. Now, if there is depolarization in the atria, there is a vector downwards and to the left. So this guy is going to see it. This lead is going to see it, right? when the lead sees this, what is depolarization? Positive charge. Positive charge. What is this electrode? Positive electrode, right? Positive charge going to a positive electrode. What is going to happen? This is going to deflect upwards. This is going to deflect upwards as the paper moves. As the paper moves. The moment it deflects upwards as the paper moves, guys, it will, now the paper is moving, it will draw a slide. It will go up and come back down. Going up and coming back down as the paper moves. So it will draw a line like this, right? Okay. Is everyone clear? Right? Is everyone clear? Does everyone get this point? As the paper moves, when the pen is stationary and it is just moving up and down, when there is atrial depolarization, there is a positive deflection up and then down. When the atrial depolarization is over, it will come back down. Okay. Right? Right. Then, so that was, let me not draw it that big. Let's draw it something like this nicely. Right? Like this. Okay. Right. So this is our P wave. This is our P wave. Right? Next, what happens, guys? The next step, guys, let me draw this here, otherwise not enough space for me. Right? I will erase a little bit of this paper. Right? You all can keep it. Right? Paper is there. I will draw it here. I will start here. Right? So we drew the P wave now. Right. So atrial depolarization is done. Next, what happens, guys? After the atrial depolarization, the next step is the impulse comes to the AV node. In the AV node, is there any impulse detected? Is there any voltage difference detected? No. Right? So within the AV node, guys, what are we going to see? We are going to see a flat line. We are going to see a flat line. Right? This is our AV delay. This is the AV delay. Right? Okay? Right. Then, come to the ventricle. Come to the ventricle. So now we've drawn this, and we've seen the AV delay. Right? Coming to the ventricle, guys, what did we have initially? We had the septal ventricular depolarization. Septal ventricular depolarization. The direction of the vector was from where to where? We had the vector, right, like this, something like this. Upwards and slightly to the right. Right? Upwards and slightly to the right. So what was that? Towards the negative electrode. So how is this ECG lead going to see it? It is going to see it as a negative deflection. This ECG is going to go down. Right? So when you have a negative deflection, how are we going to see it, guys? Like this. Right? Like this. Okay? Negative deflection. This is septal. Septal. Then we have major ventricular depolarization. How do we get major ventricular depolarization? Again, a large vector, downwards and to the left. If it is a large vector, the deflection is going to be large. Something like this. This is the next step. Right? You all can draw it one step at a time. Huh? So the next step will be like this. Right? Like that. Large vector. Right? Draw the P small, right? It's supposed to be smaller than this. Right? Something like that. Yeah. Right? So we have a large vector there. Then what do we have? Then we have the basal ventricular depolarization. Basal ventricular depolarization again was going slightly upwards. Right? Upwards means what? Away from this positive electrode. If a vector is going away from the positive electrode, right? What is it going to draw? Again, another negative deflection of this ECG needle. So it's going to draw another negative deflection. Okay. Right? Then, guys, right? After this is done, right? After this is done, what is our cell now? Our cell has been fully depolarized, right? Our cell is fully depolarized. Our heart is fully depolarized. Why? Atria have been depolarized and ventricles also have been depolarized, right? That means that the heart is fully depolarized. What did we say? If we take a piece of myocardium and all of it was fully depolarized, is there a potential difference to detect? No, right? Therefore, what is the next marking that will be drawn, right? It's going to be another straight line here, right? Like this. Okay. Finally, what do we get, guys? Repolarization. Repolarization of the heart. What did we say? Right? This is going like this from outwards to inwards fashion. Outwards to inwards fashion. Now, repolarization is what? Disappearance of positive charge, right? Loss of potassium ions. And therefore, it is becoming more and more negative. So basically what is happening? A negativity is there. And if you look at the direction, it is going more towards the negative electrode, correct? Because it's going outside to inside. So a negative charge going towards the negative electrode. This is not actually a negative, guys. It is a disappearance of positive, right? But I'm just saying disappearance of positive. That is what we call repolarization. So it is an overall negativity. Overall negativity moving towards the negative electrode. What did we say? Negative going towards negative is going to be a positive deflection. It's going to be a positive deflection. So therefore, we get the last wave here like that, right? That is our T wave. That is our T wave, right? Did everyone understand this? Right? This is how give me a second, guys. Let me find yeah, there we go. Right? This is how the basic ECG is drawn. But I want you all to remember, right? Now, this was from this lead that is looking at the ECG, right? If I draw the eye, he is looking at the heart from here, right? Now we will see in other leads how this ECG, this is the main one. This is the main ECG pattern, right? And if you all remember the limb leads, right? We said there are 3 real limb leads and 3 augmented limb leads, right? We drew them like this. Which lead do you think this is? Which lead is this? What do you all think? What were these leads? This was 1, this was 2, this was 3. And down here we had the augmented one, the AVF. Somewhere here we had AVL, and here we have AVR. What is this lead, guys? This is lead 2, right? This is lead 2. The lead I used for this example is lead 2, right? Lead 2 is the lead that gives the most beautiful ECG pattern. Therefore, we call it the rhythm strip, right? We like to look at lead 2. When we take an ECG to the hand, we love to look at lead 2. Why? It is seeing all these cardiac action potentials. It is seeing all the voltage differences at such a nice angle that it is going to give us this complete nice ECG picture, right? In the other leads, we'll see there are some differences, right? Okay, they won't see this nice picture, okay, right? So just note lead 2. This is why we use lead 2 as the rhythm strip, right? Right. Then come to the next one, right? Did everyone understand up to this point? All good? Right, let me see some faces, right? You all are tired? You all are going to faint? Anything? No, right? Imesh, all good? Yeah? Right, excellent. Right, let's move on. Now, so you all know how the basic ECG picture is coming about, right? Okay, now look at this, guys. Let me erase this. Right. If we take a look at some other leads, especially let's talk about some of the chest leads, right? If we talk about some of the chest leads, guys, now if I draw a heart, let's say like that, right? Something like this, right? And you all know our chest leads. Now I'm not going to draw that circle again, but basically we have, right, not this much, somewhere here, V1, right? V2, V3, V4, V5, and V6, right? So this is how it's looking at the heart now, right? These leads are looking at from the horizontal plane, Now look at this. If I tell you all, look at this, guys. If we are looking at the ventricular depolarization, we'll look at the entire heart's depolarization. Look at this. If we are looking around this area, this V1, V2 area, if these leads are looking at the heart, right? What do we have? Initially, we'll have the P wave. P wave will be there, no problem, because it's in the atrium, right? So it's anyway seen by all of these leads. They will all see the atrial depolarization. But then after that, we'll see the AV delay also, no problem. When it comes to the ventricular depolarization, now look at this, guys. These ones, right? If we look at, let's take specifically lead V1. When lead V1 is looking at the ventricle, what is the first part of ventricular depolarization? Septal depolarization, right? The septum is depolarized how, guys? Something like this. This is how the septum is depolarized, right? So what is this? A positive charge, right? Coming towards this V1, right? A positive charge directed more towards the V1. Everyone agrees? Right? If that is the case, should this show up? Will the ECG deflection be up or down? Will it be a positive deflection or a negative deflection? Come on. Just show up or down. Show up or down. Manari, you're showing up. Right? Excellent. So here in V1, guys, if you look, after the AV delay, it will show an upward deflection like this. Right? Okay. Then we have the major ventricular depolarization, right? So it will come like that, right? It's downwards and to the left, right? And we have the basal ventricular depolarization, which goes something like this. So here, what do we see, guys? The Q wave. The Q wave is not really seen in lead V1, right? In lead V1, we don't really see the tiny Q wave. However, you take a look at V6, right? If you take the same ECG in the V6, what you will see the P wave, yes, you will see the AV delay, the PR segment. And septal ventricular depolarization is what? Going away from the V6, right? Therefore, what do we get? Get a negative deflection, right? And then we have major ventricular depolarization and we have basal ventricular depolarization and like that. Okay. So what does this tell you, guys? Right? As we go through the ECG, the structure of the ECG changes. And tell me this here, when we look at, let me modify this a little. When we come to a V1, the basal ventricular depolarization, what did we say was the direction of the basal ventricular depolarization? Right? Upwards. We said upwards. Right? If you take this diagram like this, if you split it, basal ventricular depolarization here is going more towards this V1. So we get a very deep, S wave. We get a deep S wave. Does everyone understand? In a normal ECG, guys, when we are looking from V1 to V6, right? V3, V4, V5, and V6. In a normal ECG, when we are looking at the progression of this ECG wave, what we are going to see is a difference in the QR. P wave always appears normal, right? P wave always appears normal unless there is a pathology. We'll talk about pathologies in a little bit. The QRS complex varies based on the lead placement. So if you look at V1, guys, right, it's going to look something like this. The S segment is quite deep, right? And there is no Q. There is no Q, right? As we move on, right, the Q starts appearing little by little, and the S segment gets shorter as we move, and the R wave starts getting taller little by little, right? Something like this, right? Something like this. Right? Guys, y'all can draw it in a straight line. I'm handicapped here. Very difficult to draw on the whiteboard. Something like this. Finally, the S wave will be very tiny, right? Very tiny, yes. Now, what does this show you, guys? What does this show you? Little by little, right? The R wave is getting taller, while the S wave is getting shorter, right? Right? So if I look at all the, the maximal amplitudes, right? It's something like this. It's something like this, guys. This is what you call normal R wave progression in the ECG, right? And why is this happening? Nothing, guys, nothing complex here, just based on how these are looking at the ventricular portion and how each of these septal ventricular depolarization, major ventricular depolarization are affecting the ECG marking, right? That is all that is happening, right? Now, so if there is no proper R wave progression, we must think there is something with the depolarization spreading across this ventricle. We see it, guys, in ischemic heart disease and sometimes in heart failure, right? Commonly in heart failure, actually, right? Poor R wave progression or loss of R wave progression, right? Okay. Did everyone understand this? Right? Give me a thumbs up. Now we are getting a little bit into the right. Okay. Excellent. Right. Then, so now we have drawn the ECG. We have drawn the pattern, right? Now we'll take a look at the paper and the rates, right? This is the next important thing, right? Look at this, guys. If we take, now what is this ECG doing? It's a graph, basically a graph depicting voltage against time. Voltage against time, that is what it is, drawing like this, right? Okay. Potential difference against time, right? So, what is it actually measuring, guys? It's measuring electromagnetic forces, right? Within the heart wall, right? And therefore the impulse generation is drawn. Now, what I want you all to know is, guys, remember we said the ECG paper is being connected to a motor and it is moving while the pen stays stationary and the pen is just moving up and down. You can see. Yeah. Right? The pen is stationary. It is just moving up and down while the paper is moving. Right? It's connected to a motor here, right? This movement, right? The ECG paper movement, guys, it is happening at 25 millimeter per second rate. That is the speed. That is the speed of the paper movement, right? 25 millimeters per second. Now, don't worry, right? We'll see why that is and what is happening there. If we take a look at the ECG paper, guys, the ECG paper, right, has, right, say, large squares like this. And now I will take one of these large squares and it has small squares within that large square, right? Right? 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, right? 5 by 5, right? This is what the ECG paper looks like, right? It has multiple large squares. Now I just drew 6 here, and in one I have drawn the tiny squares inside. Look at this, guys. If we take this here, from here to here, right? Now what is the x-axis and the y-axis? X-axis is here. This is time. Right? The y-axis is voltage. This is in millivolts, guys, right? In millivolts. The voltage in millivolts, right? So same way, each of these tiny boxes, guys, or even the large boxes, this is the x-axis, this is the y-axis. The same way, right? For each box. So if we look at the x-axis, right? If we look at one of these large boxes, right? We take this is 5 millimeters if you measure it using a ruler. And that corresponds to 200 milliseconds. Why? X-axis is time. So 200 milliseconds. This entire 5 small boxes, right? If 5 small boxes is 200 milliseconds, what is one tiny box? What is one of these tiny boxes here? This is this tiny one, 40 milliseconds. 40 milliseconds. Okay, 40 milliseconds. Right? Then, when we are looking at the height, what is this? This is voltage. This is voltage, or what we call amplitude. Amplitude is voltage in millivolts. Right? When we are looking at the height, guys, again, right? Again, if you measure now, these are squares, no? These are squares. This is again 5 millimeters. 5 millimeters corresponds to 0.5 millivolts. That means to make 1 millivolt, what is happening? We need 10 centimeters. This entire thing, two large squares amplitude is 10, is 1 millivolt. Is 1 millivolt, 10 millimeters. Okay? Everyone agrees, right? 5 millimeter, 0.5 millivolt. Right? Now, so what are we saying? When we say a large square, time-wise, it is 200 milliseconds. When we say one large square, amplitude-wise or voltage-wise, it corresponds to 0.5 millivolts and 200 milliseconds time. Okay? This is the basic I want you all to understand. Right? Now, look at this, guys. I am telling you all, let me erase this a little bit. Now listen carefully. Huh? Yeah. Huh? Coming to a very delicate area. Look at this. I am telling you all, one large square, now you all know 200 milliseconds and 0.5 millivolts. When we take this 200 milliseconds, right? So how many large squares do we need? How many large squares do we need for 1 second? For 1 second? How many large squares? How many large squares? Come on. Huh? 200 into something, right? 5, huh? Right? Everyone agrees, right? 5, just give me a 5, right? Everyone agrees with 5, right? Okay. So for 1 second, guys, we have 5 large squares, right? 5 of these large squares, like 1, 2, 3, 4, 5, right? 5 large squares for 1 second, right? Then tell me this, for 1 minute, how many large squares should we have? For 1 minute, how many large squares should we have in an ECG paper? Huh? Maths. 5 into 60, right? 5 into 60. What is 5 into 60? Huh? 300. 300 large squares are there in the ECG paper for 1 minute. For 1 minute. Okay. Right? Is everyone clear about this? Right? Now look at this, guys. Why is understanding this important? Now, right? So I hope you all have written this down somewhere. Huh? I'm going to erase it because I need this space. Right? Now, if we take, now I'm telling you all, now you all can answer. I am telling you all, right? We are getting the ECG paper coming out of the machine, right? And in that ECG paper, let me first draw. Okay, let me draw it like this. I will first draw it. All right. I'm drawing large squares. Huh? For this one, I'm not going to draw the tiny small squares inside of these, right? Not necessary. I'm going to tell you all, there is an ECG paper coming out. This is the ECG paper coming out of the ECG machine. And it has drawn a pattern like this. Look at this. PQRS. 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 It's not very accurate, but you all get the point, right? What do you all see here, guys? For every one large square, there is one QRS complex. Everyone agrees, right? For every one large square, there is one QRS complex. If there is one QRS complex for every one large square, what is the occurrence rate of these QRS complexes? How often are these QRS complexes occurring? Per minute. Come on. Per minute, if there is one QRS per one square, per minute, how many QRSs are being drawn? Huh? Now tell me, per minute, how many large boxes? Per minute, how many large boxes? 300. 300, right? So if there is one QRS for each box, per minute, how many QRSs are there? 300. 300, right? So per minute, if there is one QRS per large box, right? For 1 minute, there will be 300 QRS complexes. 300 QRS complexes, right? Okay. Now, right? This is the importance of this. What does this tell you, guys? Right? How do we look at the QRS complexes? How do we basically look at how many QRSs are there? We take a look at the R wave because R wave is very large. No? We can easily see when we take the ECG paper, R wave is very large. So we take a look at the R waves, right? And we check how many R waves are there with how many large boxes, right? So if, right, now you all can write this down. If there is, what we call, guys, between the R waves, we call this the RR interval, RR interval, right? So if the RR interval is one large square, what does that tell you? RR interval is one large square means for every large square, there is one R, correct? Every large square, there is 1 hour. If that is the case, for 1 minute, we are getting 300 hours, or in other words, 300 QRS. Right? Lula, understood? Understood? Right? Okay. I'm a little bit afraid because this, right? I'm just checking your faces, right? Manari, all good? Right? Okay, good. Himesh, I know you're good. You're nodding your head, so I'm. Dilmi Tilakaratna, I can't really see your face. Is it all good? All clear? Right. Okay. Right. Then, now tell me this. Based on this, we can check the rate of the this ECG rhythm, right? What do I mean by that, guys? If the RR interval, we can check the RR intervals, right? And correlate that to the number of QRS. Now, the number of QRSs, guys, what do they correlate to? Whenever in the heart, what did we say? Electrical activity first, then heart contracts. Mechanical activity. Electrical activity goes first, then heart contracts, right? So if this is the case, when there is 1 QRS coming out, just the moment after that, what will happen? Ventricle will contract. Ventricle will contract, right? So if there are 300 QRSs, what is that? What do I mean? There are 300 ventricular contractions occurring within this 1 minute, right? Everyone agrees? So that is a heartbeat. 1 ventricular contraction is 1 heartbeat, right? Right? Okay. So we are going to look at the RR interval compared to this QRSs, right? In terms of beats per minute. In terms of beats per minute. So what do I mean by that? If we have the RR interval is 1 large square, 1 large square. That means what? 1 R is occurring for every large square, right? If that is the case, what is the QRS rate? 300. So the heart rate will be 300 beats per minute, right? Now let's say the RR interval is 2 large squares. What do I mean by that? Every 2 large squares, we have a QRS. What does that look like, right? We have 1 QRS here. Then here nothing, here nothing. Again this one, second square. Here nothing, again here, right? Okay, so every 2 large squares, we get 1 QRS complex, right? If that is the case, guys, what is the amount of QRSs that are coming in 1 minute? It's going to be half of this. So we have 150 QRSs coming for 1 minute, right? Is everyone clear about this? Right? Same way, 3 large squares. If we take 3, what is that going to look like? 1 QRS here, then this one nothing, and here. Then this one nothing, and somewhere here, right? Every 3 large squares, we are getting 1 QRS complex, right? So the RR interval is 3 large squares. If that is the case, what is the beat, guys? Here it's about 100 beats per minute, right? And for 4, right, we have 75. For 5, we have 60, right? Like that it goes on. For 6, right, we have 50, right? Like that it goes on, right? Okay. So now based on this, if we are looking at a normal person's normal sinus rhythm, normal heart rate, what is the normal person's normal electrical activity? 60 to 100. 60 to 100. We said that at the very start. That means what? If you take the heart rate, it's 60 to 100. That means what, guys? If you check the RR intervals in a normal person's ECG, it should be where? 60 to 100. 60 to 100. This means what? 3 to 5 large squares. The R waves, right, should be occurring between 3 to 5 large squares. 3 is fine. If it is occurring every 3 large squares, it's fine. If it is occurring every 4 large squares, it's fine. If it's occurring every 5 large squares, it's fine. That is normal. That is normal. But if it is occurring less than 3 or more than 5, then either if it is less than 3, what is it? Here, look at the heart rate, 150 or 300. That is tachyarrhythmias. Those are our tachyarrhythmias. If it is occurring less than 5, right? That means what? Less than 60 beats per minute. What is that? Bradyarrhythmias. Bradyarrhythmias. Okay. Did everyone understand this concept? Right? Okay. So the RR intervals is what we use the moment we get an ECG, right? I will teach you how the order is to read an ECG, right? The moment we get the ECG, we are going to use the RR interval to check if the rate is normal. Check if the rate is normal. Okay. Clear? Clear? Right. Then guys, now majority of ECG, now it's going to be very easy, right? Now, look at this. Let's come to the next part. Look at this, guys. Now, what I want you all to understand. I will draw about, right, 3 ECG waves. You all can draw it in a nice straight line, right? Just to, not necessary to draw 3, even if you draw 1 big one, it's enough. But just otherwise it's going to be congested here, right? Look at this, guys. Some important points about the different waves that you all must know for your undergraduate curriculum, right? Look at this. P wave. what is the important thing to know here about the P wave? The first thing I want you all to know, P wave should be, the duration of the P wave must be less than 120 milliseconds. Now, tell me, 120 milliseconds means how many tiny squares? How many small squares? Come on, tell me. 120 milliseconds. How much was one tiny small square? 40 milliseconds. 40 milliseconds, right? So 120 means what? Maths, right? 3 small, it's 4, 4, 8, 12, no? Right? 3 small squares. 3 small squares. So the P wave must be less than 3 small squares. Less than 3 small squares. Okay, this is in the normal ECG, right? Okay, right. Then we'll come to the next one. Here, guys, just before we go, just I want you all to know, so what is an abnormal P then? If it is broader than 3 small squares, it's an abnormal P. Here, guys, there is another one. So one is it can be broad. Broad P wave is abnormal. If there is a broad P wave, what does that tell us? There is a slower conduction within the atrium. That's why it's broad. Why? The needle deflection has been very slow, right? So therefore, when the paper is moving, the ECG is going to draw broad one, the broad one, right? Right? So here, in the same way, another abnormality that sometimes we can see is something like this, guy. What is this? Look at this. The P wave. Looking something like this. What do you all think is going on? Look at this, guys. Now we know P wave is what? P wave, right? It is the depolarization of the atria. So we have a right atrium and a left atrium. But do we see these two depolarized separately? No. In the ECG, it will draw only one P wave. It doesn't draw two P waves, no, right? The ECG shows it as one P wave because these are occurring simultaneously, right? The wave of depolarization. However, in certain conditions, you can see a separation of the P wave, right? Right? Something like this. Something like this. What do you all think can cause this condition? What do you all think? Come on, think about some abnormality within the atria that can probably give rise to this. What do you all think? Come up with something. What do you want to think? Huh? Shamodya, come on. Can't stay muted all day. Right? Okay, come on. Just try to guess something wrong within the atrium that can result in this kind of a pattern.
Maybe an issue with the SA node.
Okay. No, we are specifically talking something about the atrium, not about the SA node, right? Not about the, if there was some, now we will see some nodal arrhythmias. We will see some SA node related sinus arrhythmias, right? This is not that. This is now what is the P wave signifying? Atrial depolarization. If the P wave is showing something like this, there is some problem within the atrium. What can happen is, guys, look at this. Imagine this left atrium was thickened, right? Thickened. What we call hypertrophy. Now, in the initial diagrams of our cardiac muscle slices, remember we drew the slices. What did we say happens whenever there is a thick portion of myocardium? Whenever there is a thick portion of myocardium, for that piece of muscle, there is a large vector generator. So when there is left atrial hypertrophy, guys, what will happen? This is the normal P wave. The ECG will also see a thick vector, right? This vector will be normal, like this. But here in the left side, it will be a thick vector, right? Something like that, right? And the ECG will detect it as a separate wave, right? This is what we call a broad bifid, right? We call this bifid P wave, guys, right? So a broad bifid P wave is an indicator of left atrial hypertrophy, right? And we see this where? Where do we see left atrial hypertrophy? Last week we talked about in our ischemic heart disease class, right? In certain conditions, mitral stenosis, right? It can lead to left atrial hypertrophy and atrial fibrillation as well, right? Okay, so that's where we see these broad bifid P waves, right? Okay, then let's move on, right? Right? So that's about the P wave, what I want you all to understand about P wave. Then about the QRS. The QRS, where is the QRS? From the beginning point of the Q, then we go to the R and the end point of S. From the starting point of Q to the end point of S. This is our QRS complex. The QRS complex, guys, again, this should be less than 120 milliseconds. So like the P wave, the entire QRS complex should be less than 120 milliseconds. If it is more than that, we call it a broad QRS or a wide QRS. Okay, right? So this is again less than 3 small squares. The QRS complex. Now, right, RR interval from one R to the other. What is the normal RR interval? Come on. What is the normal RR interval? Unmute and say. What is the normal RR interval in you and I? Huh? Come on, guys. Unmute. Huh?
3 to 4.
3 to 5, what? Small squares or large squares?
Large squares.
Large squares. So write those down. Huh? Now don't, otherwise you always mistake with these. Write small squares where it's needed and write large squares where it's. So this is 3 to 5 large squares. Large squares. Okay, good, excellent, excellent. Right? Then, so that's about the QRS complex, right? Then guys, here, the T wave, this guy, the T wave, right? The T wave represents what? Ventricular repolarization. Ventricular repolarization. Now tell me this, guys. In our normal ECG, right, we see atrial depolarization. We see ventricular depolarization. And we also see a ventricular repolarization. What about, now no one asked me, what about atrial repolarization? Where is atrial repolarization in our ECG? What do you all think? Where is it? Do you all see it anywhere here? Can you all see it here anywhere? In the ECG that we've drawn? No. Right? What is happening is, guys, atrial repolarization happens somewhere hidden beneath this QRS. But what did we say? ECG machine loves to look at thick myocardium, right? Right? He loves to look at thick myocardium, right? Okay, Imesh, right? So what is going to happen, right? He is not going to see the thin atrial repolarization occurring. He doesn't care about that. He sees the QRS, right? And he's going to see that fellow and he will draw that, right? So the atrial repolarization is occurring, guys. We are not saying that the atrial repolarization doesn't occur. It's just that the ECG machine does not detect it because there is a very much larger vector for it to detect in the ventricles at that same time, simultaneously. Okay, right? Okay. Then, so the T wave is what? Ventricular repolarization. The T wave, guys, a few things I want you all to know. One thing, right? It can be inverted in some LEDs. What do I mean by that? Now we drew, guys, remember, if you all remember, if this is the heart, we drew the limb LEDs, right? And we said there were some, right? This is 1, 2, and 3. And we said the augmented leads were here, right? Something like this, right? We had AVF here and AVL and AVR, right? Now look at this, guys. LED AVR. If you look at LED AVR, now from where to where is repolarization happening? From outwards to inwards. And what is this? A negativity, overall negativity coming like this, right? Overall negativity coming like this. The AVR, guys, right? In AVR, when he sees negativity coming towards him, right? When he sees negativity coming towards him, AVR is not, these are not positive electrodes. These are just electrodes. They're just looking at the heart's electrical activity. When he sees a negativity coming towards him, he will draw it as a negative deflection. So even in AVR, guys, even the other ones, even if you look at the QRS in the AVR LED, it looks more negative like this. Draw something like this. More negative than the other leads. Something like this. QRS also looks very negative in the AVR. Why? Because of its location. Now this is not a real LED. This is a augmented lead, right? We get it using a calculation, right? So in the AVR, guys, T wave is also inverted and QRS is also more negative than other LEDs. Okay. Just remember that. So that is normal. Huh? The T wave being negative in AVR is normal. In you and I, that is what we're going to see. However, there are some pathologic conditions where we see T wave inversions. Like last week, we talked about ischemic heart disease, right? In non-ST elevations, we said there can be T wave inversions, right? Even in ST elevations, sometimes there can be T wave inversions, right? We have discussed those. Then, there is also another condition, guys. This is not really necessary for MBBS. You all have heard the drug digoxin, right? In digoxin toxicity also, there can be a T wave inversion. For now, you all can just write it, not really tested in your undergraduate level, right? Just keep it written down, okay? There's actually a characteristic pattern for digoxin toxicity, right? We'll talk about that someday when we are discussing heart failure, right? Okay, so that's about the T wave. Then, now we'll come to these intervals and these segments. What did we say? What was the first one? This tiny guy here, right? From the end of the P to the start of the QRS. What was this? This was the PR segment. Now, I don't know who named this, right? From the end of the P to the start of the Q. If it was me, I would call it PQ segment, right? So I don't know, right? So we have to be thankful for whoever who started that, right? So this is called the PR segment. Can't help, right? PR segment. PR segment signifies what? AV nodal delay. AV delay. Okay, right. Then, guys, we have another, the PR interval. What is this PR interval? From the start of the P wave. Up to the start of the Q wave. So this. from the start of the P up to the, again, if it was me, what would we have called it? The PQ interval, right? But it is the PR interval, constant, right? PR interval, right? Here, the PR interval. So what do I want you to know? The first thing, PR segment is not the same as PR interval. Okay, PR segment is not the same as PR interval. The next thing I want you to know, PR interval, guys, PR interval should be between 120 to 220 milliseconds. Now, what does the PR interval show? PR interval is showing us atrial depolarization as well as the AV node delay, both together. So both of those together should be about 120 to 220 milliseconds. So if we are talking in small boxes, what is that? 120 to 200, 120 to 200, 120 to 200, right? So if you're talking in small boxes, how much is that? One small box is 40 milliseconds, right? So 3 to 5 small boxes. This should be the PR interval. Now, why we need to know this one, 3 to 5 small boxes? This is important. Now, even this, when I say something is important, guys, you all have to take it a little bit into your mind. These ones, yes, it's good for you to know. But now the P wave duration, not very significant unless we can see a nice broad bifield P wave, especially for your undergraduate level, not really necessary. But PR interval, very important. Because we are going to talk about something called heart blocks, right? That is absolutely necessary for your level, right? So in heart blocks, you need to count how many small boxes are there within this PR interval and make an assumption there, right? We'll see why. Understood? Everyone clear? Right? Okay. Then guys, so what is this PR segment used for? What is this fellow doing here? Why do we need it? Look at this, guys. What is the PR segment showing? AV delay, right? During this time, there is no voltage change. We consider it no, although there is a current passing, it is absolutely negligible, right? So we don't consider it. The ECG machine also doesn't care about it. So here, guys, this PR segment represents, whenever there is this flat line, the PR segment represents the baseline of the ECG. Why is this important, right? Next we get the QRS now. After that, what do we get? From the ending of the S to the starting of the T, we get something called the ST segment. Now, when we were discussing myocardial infarctions, we talked about ST elevations or ST depressions. So what do we do, guys? We are using this PR segment as a marker of the baseline, and we are comparing how much the ST has gone up or how much the ST has gone down, right? So that is the job of PR segment. PR segment does nothing else. He is just acting as a marker of the baseline so that we can see if the ST segment has elevated or not. There we talked about something called J point also, if you all remember. That was here, right here. That was the J point, right? If you all haven't watched the lecture, you all can check it out. It's on YouTube, right? So that is the job of the PR segment, right? Then guys, here, there is another interval here, right? Somewhere here, let me draw it like this. From the start of Q, right? To the end of the T. Start of Q to end of the T. What is this? QT, right? QT, right? Now some of you must have used that on your girlfriends and boyfriends also. QT, right? Like that. QT, right? This fellow is very cute. Now look at this. Why is this very cute, guys? This fellow is annoying. What do I mean by annoying? This fellow varies with age. He varies with sex. He varies with gender. He varies with race, right? Such a lot of variations in this QT interval, what we call the QT interval, right? Therefore, it is difficult for us to say, okay, in you and I, the QT interval should be like this. It is difficult to give a range. Therefore, what our scientists have done, they have made some formulations and they have removed those biases, right? We don't need the math there. They have removed those biases to come up with something called QTC. What is this QTC, right? Corrected QT interval. What is this corrected QT interval? It is corrected for the biases. All the biases are removed, right? So we don't care about age. We don't care about race, nothing. We can say normal range QT is this much, right? So this corrected QT, guys, actually there is one bias in males and females. Only the sex. The sex is the only bias we have, right? All the other biases have been removed. Age bias removed. Everything else is removed, right? So in males and females, it's slightly different. What I want you all to remember, especially if you all are first year to third year, fourth year, it's fine if you all remember 450. The corrected QTC should be less than or equals to 450 milliseconds. 450 milliseconds. If you all remember this, for majority of your MBBS also, it's fine. The slight difference here is, guys, it's actually for males less than 450, and for females we say less than 470. Less than 470, right? If you all can remember this. By all means, do so. Otherwise, just remember this. This is important, right? Now, here, the QT, why is it important, guys? There can be certain conditions that are causing prolongation of this QT. Prolongation of the QT, giving rise to certain arrhythmias. We'll talk about those, right? Did everyone understand all of this up to now? All good? Right? One last thing, guys. Sometimes, after a T wave, we can see another tiny wave. Sometimes, not always. This is what we call the U wave, right? The U wave. What is this U wave and why is it coming here? This U wave, guys, it is a representation of repolarization, right? Repolarization of the papillary muscle. Papillary muscle, right? Papillary muscle, right? Repolarization of the papillary muscle. Now, you all know in our heart valves, right? They are connected to something called the papillary muscle, right? Via the quadra tendinae. That's how they contract and open and close the heart valves, right? We'll talk about those in valvular heart disease. But what I want you all to know, if you all are seeing ever in an ECG for your undergraduate level, just know in an ECG, guys, if we are seeing a very tall tented T wave, right? In an asymptomatic patient, usually if they don't have chest pain or anything, and they're showing a tall tented T wave, what is our first suspicion? Hyperkalemia. Hyperkalemia. Like that, if there is a flat T wave, and a U wave also present, flat T wave and a U wave also present, then we must suspect hypokalemia. Hypokalemia. Okay. Hypokalemia. A flat T and a U wave C. Right? We must suspect hypokalemia. Okay. If you know that much, more than enough. Did you all understand all of this? Now here I know there are some, that's what I'm saying, guys. Whenever we come to some places where you must know some facts rather than understanding, it's here. We understood most of the concepts. Are these numbers? It's a little bit of a memorizing game, right? You all have to know these numbers a little bit, right? Okay, so number memorization, guys, not a problem. 1 week before the exam, go for the exam, right? Number memorization is not the issue. But if you all understood the concept, that's what's important. Okay, everyone good up to this point, right? Give me a thumbs up, right? Okay, then, guys, we will go to the next concept here, cardiac axis, right? Look at this. Cardiac axis. What is this cardiac axis and what are we looking at here? Look at this, guys. Cardiac axis. Basically, what is this? We are looking at the direction. Now, we've already looked at so many vectors. We are looking at yet another one. We are looking at the direction of the heart's depolarization in the frontal plane. What do I mean by frontal plane, guys? Here, right, we are going to use our frontal plane vectors, right? What was our leads here? Remember, 1, 2, 3, right? 1, 2, 3. And we had AVF here, right? AVL and AVR, right? Look at this. This is our frontal plane. These are our frontal plane leads. Now we are going to look at the direction of the cardiac depolarization wavefront in this frontal plane, right? Look at this. Primarily, guys, we are going to use lead 1 and AVF. And sometimes we can use 2 as well. No problem. But primarily these two, right? The moment you get the ECG paper to your hand, if the examiner tells you, tell me the cardiac axis of this, you're only going to look at 1 and AVF. You can take a little bit of help from 2 as well, right? That's what I mean, right? Right. Let's take a look at this. Now, if I'm telling you guys, okay, I'm giving you an ECG paper. You look at lead 1, right? You look at lead 1. The QRS complex in lead 1 looks something like this, okay? And the QRS complex in lead 2 looks something like this, very similar. The QRS complex in lead 3 looks something like this, very similar. Same QRS seen in all 3 leads, right? Where do you think is the direction of the major vector in this? The major vector should be between here to here, no guys? Everyone agrees? Because of that, the QRS is a very upward deflecting positive QRS, right? The cardiac vector is somewhere along this direction. Everyone agrees, right? So this is what we call the normal cardiac axis, guys. Why? We said the normal cardiac major depolarization is downwards and to the left, right? So in you and I, if you look at the cardiac axis, on lead 1 QRS is a positive, nice, large QRS. Lead 2 positive QRS. Lead AVF also positive QRS. Because why? The cardiac axis, the direction of the wavefront is this downwards and to the left. Right? Here, guys, actually they put values, right? They put values here. This is 0 degrees, right? 0 degrees. Then here, we can say somewhere here is positive 90. Right here, if I draw a dotted line like this, this is 180, right? 180, right? And here is negative 90, right? This is how they usually say. So the normal cardiac axis, right? Normal cardiac axis, guys, this is usually, right? 0 to plus 90, right? Okay, but we do accept a little bit, even if it is, we do, in books you always see, they even accept a little bit up to here. This portion also they take it, right? This portion also is coming under the normal cardiac axis, right? So that is the vector direction, guys, because the vector is going like this and one major vector going like this. Therefore, the total summation of the vectors is downwards and to the left, right? So this is about minus 30, right? So the normal cardiac axis, we say, is from minus 30 to positive 90 degrees. How do we, I don't even want you all to know these degrees, guys. This is just for you all to understand when you all read books. But when you all get the ECG paper, what do I want you all to see, right? Lead 1, positive QRS complex. Lead 2, positive QRS complex. Lead ABF, positive QRS complex, right? If that is the case, that is a normal cardiac axis. This patient's heart is functioning fine. Nicely, the impulses are flowing with the major current depolarization downwards and to the left. He is normal, right? Right. Then, let's say, I gave you, now I have to erase all of this, no? Okay, now, let's say I gave you another ECG, right? Let me erase these a little bit, right? Like that. Right. I gave you another ECG, right? Oh, lead 2. I have to draw lead 2. Lead 2 somewhere here, right? Okay. I gave you another ECG. Let's say you look at lead 1. Lead 1 is a nice positive QRS complex. Nice positive QRS complex. But, right, you look at ABF next. When you look at ABF is very negative ABF. The QRS complex is a negative QRS complex, right? And you look at lead 2 also. Lead 2 is also showing a negative QRS complex. Okay. Now, based on this, what do you all think? Here, guys, right? The where do you all think is the vector? Vector. It is somewhere here, guys, right? Now, this guy is positive. This guy is positive. So from somewhere here, all of this, right? The vector should be somewhere within this, right? The major vector direction should be something like this, right? Okay, right? Okay. More towards this AVL side. So when this is the case, guys, now if this is the heart, this is in the middle, I have drawn the heart. Where is this vector going to? More towards the left upper side. Not downwards and to the left. Previous one, normal axis, downwards and to the left. This is left upper. For this, we call an axis deviation. Therefore, we call it left axis deviation. Right? Left axis deviation. Now look at this, guys. If I'm drawing a heart here, right? Like that, right? Like this, right? And I'm telling you, so let's say SA node, AV node, and then you had the 100 branches and the spread like this, right? Now I'm telling you, due to some reason, the cardiac axis, the major vector is in this direction, right? It's in this direction. What do you think can cause this? Huh? What do you all think? One reason, guys, just imagine, just logically think, huh? Imagine the left ventricle is hypertrophied, right? Can happen, right? So when there is a left ventricular hypertrophy, the cardiac axis is going towards the left. Right? Then guys, there is something called, now we'll talk about bundle branch blocks. I'm going to teach you all today. There is something called the left bundle branch block, right? When the left bundle is blocked, guys, there will be impulses coming from the right to that left, right? Don't worry, I will teach you all. For now, just write down left bundle branch block also can cause a left axis deviation. Then another one, let's say, this one you all have already studied with me last week. Let's say somewhere here on the inferior wall, on the inferior side, right? More towards the right, there was a myocardial infarction. Let's say there was a transmural myocardial infarction. What did we say happens when there is myocardial infarction? There is hypokinesia, right? Impulses are usually not being transmitted across that region, right? Therefore, what happens, guys? Again, any impulses will come towards the other side, right? Okay. So again, right, even inferior wall myocardial infarctions. So these are the three main ones I want you to remember. Left ventricular hypertrophy, inferior wall myocardial infarctions, and left bundle branch blocks, right? These three can cause this left axis deviation. How do we see left axis deviation, right? On lead 1, you will get a nice positive ECG. Now, this is what I don't want you all to memorize, guys. Now, even for me, so we learned ECG, I think somewhere in third year, right? If I'm correct, I cannot remember now. But what we were taught was the thumb method. Now, I put the thumb method in your note also, right? So what they say is take the ECG paper, look at the left and the right thumb up, right thumb down, right? At the end, towards the end of the semester, when you're coming to go to the exam, you don't remember what is the left thumb, what is the right thumb, right? If you understand this, see how easy. You just look at lead 1 and you all know where lead 1 is in the cardiac. If you all remember this 1, 2, and 3, that's all you need, right? How it is placed, right? If you all remember lead 1 is here. If lead 1 is positive, QRS, and these two are negative, you know the impulse is not flowing this way. Major vector is going somewhere there. So that's a left axis deviation, right? Very easy, right? Right. So that is left axis deviation. Now let me erase this again, right? Do that, you know. You have to get one of those boards where when you press the button, everything automatically erases. How to get boards, guys, now with our economic situation, right? Okay, even purchasing a Zoom account is not easy now, right? Okay, let's take a look at this, right? Now, let's say, okay, we got another person's ECG. Let me erase this. Another ECG thing, right? In this person's ECG, you look at lead 1 first. You look at lead 1, right? It's a negative QRS. It's a majority negative QRS. That is, what is the first thing? It is definitely not going, the major vector shouldn't be towards this left. Something is else wrong somewhere, right? And you look at the AVF. AVF looks positive, nice positive QRS. And you can draw it straight. I'm just nice positive QRS in AVF, right? Therefore, what needs to happen, guys? Where is now even lead 2? Let's say even lead 2. You look at lead 2 next. That is also nice positive one. Nice positive one. So where do you think, guys, the vector direction is? It is somewhere from here to here, right? Somewhere from here to here, right? Like this, right? The major vector direction is like this. What is this? Downwards and to the right, right? Downward and to the right. Okay. So what is this? This is a right axis deviation, right axis deviation. Okay. Clear. Now, so how do you identify right axis deviation? You look at lead 1, it's primarily negative, right? And you look at lead 2, often not, but AVF definitely, right? AVF, most of the time you will definitely see a positive one. Sometimes lead 2 can show an unclear image. Sometimes it can show a negative. It's not very reliable. That's why I said we primarily use lead 1 and lead 2, lead AVF. 1 and AVF you use only if it is not clear. Only if your diagnosis is not clear, you take a look at 2, right? To come and add to your diagnosis of the axis deviation. Otherwise, 1 and AVF is enough, right? Sometimes 2 won't show, right? That's what I'm saying. So you look at lead 1, negative reflection. You look at AVF, positive reflection. This is right axis deviation, right? Okay. Impulse, the main vector is here. Right axis deviation, guys, just remember, I want you all to remember now in right bundle branch block. Don't worry, we are talking about the bundle branch blocks in a little bit. I'll teach you all, right? You can see it here, right? Right ventricular hypertrophy. Again, you can see it there, right? Thickening of the right ventricle, right? And there can be some, you can write down left lateral MIs, left lateral myocardial infarctions also. This can be seen, right? Okay. Right. And sometimes, guys, for the seniors, you all might have heard something called posterior fascicular heart block, right? We're a little bit advanced. If you all want to write down, you all can write down, but not real necessary, right? Did everyone understand up to this point? Right? All good. Right. Then there is one more, guys. There is one more here to teach you all, right? Look at this. You all look at lead 1. You all look at lead 1. It's negative, right? You all look at AVF. It's negative. You all look at lead 2. It's primarily negative QRS. What does this tell you? What does this tell you? The axis is probably somewhere here, right? Everyone agrees, right? Somewhere here, right? Going away from all of these 3, right? Going completely away from all of these 3. What is this? This is what we call extreme axis deviation. Extreme axis deviation, right? Or in some books, guys, some old books, they call it the northwest axis, right? Extreme axis deviation. This one, guys, right? Absolutely unnecessary for your undergraduate level, right? There are some specific conditions, some pulmonary embolism, COPD, right? Even Wolff-Parkinson-White syndrome can be related, right? Not necessary. Just know that there is such a thing. Just know that there is such a thing for undergraduate level. That's it, right? Okay. Right. From today onwards, my students, are you all going to be doing this during exams? No. Okay. Right. I'm telling you all because I tried that method. It did not work. At that exam, with the exam stress, you're trying to mark an MCQ. This will not work. Okay. Right. Okay. It's okay to go through that. I put that in your note as well because it was from my note during my school, my university time. So I've made those notes back then. So I put it there, but right. Better to just understand. Very easy. Very easy. Right. Okay. Is everyone clear up to this point? Right. This is the basic section for today. Now I know it's already 2.5 hours gone. Now, guys, I'm giving you all an option, right? We can have a 10-minute break and go ahead with the rest. Or we can go through the rest also. What do you all think? Just drop a message in the chat. You all want a 10-minute rest or what? Come on. Right? Because I know today is tiring. I know today is a tiring session. So let me know. Just drop a message in the chat. Huh? Don't be shy. Right? No one's going to say anything. Right? Come on, quickly. We can't waste time. Huh? 10 minutes. Okay, we have Dinita. Okay. Anyone else? Come on. I can't. This has to be democratic, no, guys. I can't. I can't base off of one vote. Come on, tell me. Huh? Right? Okay. Right. So okay, 2, 3. Okay. So there are 15%. So I got only 1, 2, 3, 4. I've got 4 votes. Okay. But okay, I will give 10 minutes because I understand today's concepts are a little bit heavy. So let's take a 10-minute break. Go walk around your rooms. Go wash your faces a little bit. Bring something to eat. No problem eating in front of the camera. Huh? If you are eating, no issue at all. Right? 10 minutes rest. Right? Let's come back. Right. Is everyone back? Let me start again. Guys, turn on your cameras. Right. Okay. All good? Can you all hear me? Give me a thumbs up, yeah? Okay. Right. Right, okay. Right, let me share the screen, guys. Can you all see the screen? Yeah? Right. Right, look at this. Now, look at this diagram. Look at this ECG. Tell me what is the axis here, guys? What is the axis here? Come on. Tell me. Look at lead 1 first, then look at AVF, the VF, right? And then look at 2 also. What do you all see? Come on. Unmute. Or send a message if you all are shy. Come on, guys. Let's go ahead. Right? We have a little bit more to do today. What is the axis you all see here? Well, sending messages. No, right? No. Still didn't get a message. Come on. Unmute and talk, guys. Unmute and talk. Who is here? Dulashi. What is the axis here?
Right axis deviation.
Right axis deviation. Right? That's it. So, unmute and talk. Dulashi, which year are you?
Fourth.
Fourth year. Right. Excellent. Right. So, you all have understood that. So, let's move on. Now, guys, we are coming to this. Now we are coming to the pathologies, to the diseases. When you all get an ECG, what do you all want to look for? The disease conditions, right? Because we've talked about the normal ECG, the normal cardiac axis and all of that, how to see. Now we'll talk about some diseases. Look at this, guys. Firstly, right? We are looking at the sinus node rhythm and any abnormalities that are there, right? What are these, guys? What do we mean by a normal sinus rhythm? Firstly, the origin of it should be from the SA node, right? Everyone agrees, right? The rate should be about 60 to 100 impulses per minute. That corresponds to 60 to 100 beats per minute. We understand this, right? And guys, there must be a P wave and then a QRS. Again, a P wave and then a QRS, right? If there is a QRS without a P wave, now that is a problem. That is not the sinus rhythm, right? If there is always a P wave and then a QRS complex following that, this is a part of sinus rhythm. And another point here to mention, usually when it's sinus rhythm, what did we say about the RR interval? RR interval is about 3 to 5 large squares. RR interval is about 3 to 5 large squares. Now, there is something called physiologic sinus arrhythmia, guys. What is this and why is this happening? Now, if we take a look, we know that our heart is under the influence of the autonomic nervous system, right? Especially from the vagus, we get a supply to the heart as well, right? But I want you all to know, guys, right? Here, if I draw like the brain here, right? And we have the vagus coming somewhere from the medulla, right? I'm not going to draw the exact locations, right? From the medulla, let's say the vagus nerve is coming and it is supplying to the SA node. Our SA node is here, right? What is this doing, guys? Right? Whenever the vagus sends a stimulatory signal, the SA node activity drops. Therefore, what is happening? Heart rate is dropping. If we can do something and inhibit the vagus nerve, if we can inhibit the vagus nerve function, what is going to happen? Heart rate will increase. SA nodal activity will increase. Everyone understands this concept? So if you all understand that, guys, look at this. Now I am telling you all, let me erase these a little bit. Now I am telling you all our respiratory patterns, right, have an effect on the medulla and the what we call the vagus nerve activity, right? What do I mean specifically by that, guys? Whenever we are inspirating, this has an inhibitory effect on the vagus, right? Whereas whenever we are expirating, right? This has a stimulatory effect on the vagus. Therefore, if I'm inspirating, if I'm taking a deep breath in, right, what is going to happen? Vagus is going to get inhibited. When vagus gets inhibited, what happens? The SA nodal inhibition is going to drop. SA nodal inhibition drops. In other words, SA nodal stimulation will increase a little bit. Therefore, what happens during inspiration, guys, the heart rate will increase. Now, this you all can notice even in yourselves. If you all keep the step, right, and just listen. When you all are breathing deeply in, heart rate is slightly increasing. When you all are breathing out, heart rate drops. This is because of this vagus nodal activity. Now, this here, you can see it. I've drawn it in this graph. You look at the airway partial pressure of oxygen, right? When partial pressure is increasing, what does that tell you? We are inspirating, right? Tidal volume is also increasing here, right? So whenever we are inspirating, taking in air, what do we see? The R waves are occurring much more frequently, right? These three, right? Whereas when we are expirating, that is when the partial pressure of oxygen reduces, right? Guys, can you all see my screen? Okay, I'm sorry. Give me a second. Guys, can you all hear me? Give me a thumbs up. Can you all hear me? Guys, can you all hear me? Can you all hear me? Yeah, you all can hear me, right? Okay. Sorry for that. Right, something wrong here. Right, look at this, guys. Where did we stop? Just give me 1 second. Huh? Can you all still hear me? All good? Yeah? Okay. Right. Look at this. Yeah, you all can see the screen, right? Yeah? Okay. Right. Look at this. Here, guys, what is happening whenever we are inspirating? What did we say? The heart rate will slightly increase. Whenever we are expirating, what is happening, right? Here we can see the part in green, right? What I've drawn, right? Partial pressure of oxygen is dropping, right? And here you all can see the gap between the RR intervals, the gap between the R waves is increasing. What is that? It is going into a slight bradycardia. Now this, if we take an ECG paper, guys, in the ECG paper, you all will get about, let's say in one lead, right? You all will get about 6 or 7 QRS complexes, right? That is the normal ECG paper that we get. So we won't usually see this. But if you take now here, how many QRS complexes? They have taken a large amount of QRS complexes and shrink it. When you shrink it, you can see this significant difference like this. Okay. So usually, so this is normal. This is physiological sinus arrhythmia. This is normal. Then, right. So what is the important thing here, guys? Sometimes, right, in patients with conditions like diabetic neuropathy, when they are having those kind of conditions, guys, this physiologic sinus arrhythmia disappears, right? So that can be a little bit of a problem. We'll talk about that in a different class, right? Then once you've understood that, what is the next thing I want you all to do, guys? This other sinus arrhythmias, sinus tachycardia. What is sinus tachycardia, right? Impulses are originating from the SA node, right? Impulses originating from the SA node. From the SA node, they are coming to the AV node. From AV, they are being transmitted down. The only thing you see in these people, it's a nice QRS complex, nice P wave, everything is nicely there. The only thing is you all see, right, the RR interval is seen to be reduced, right? But again, these are nice regular QRS complexes, nothing. It is just sinus tachycardia. So how will this be brought about, guys? If you're doing exercise, you and I, this is what we get, a sinus tachycardia, right? Then there are certain other conditions like thyrotoxicosis, guys. The basal metabolic rate is high there. Therefore, there can be an increase in heart rate, right? Even fever. If you all are having a fever, there can be a slight increase in heart rate. This is all sinus tachycardia, right? Sinus bradycardia, the same way. Nice P waves, nice QRS complexes, everything. Just that the gap is a little bit longer, right? The gap is the RR interval is prolonged. RR interval is prolonged. Everything else is normal. Everything else is normal, right? So where do we see this? Athletes, right? Hypothyroidism, right? This obstructive jaundice, guys. This is another chapter. We'll talk about this later. In obstructive jaundice, right? There is what you call conjugated bilirubin that is coming into the blood circulation, right? We'll talk about that later. Don't worry too much now. This conjugated bilirubin has a direct inhibitory effect on the SA node, right? Therefore, it can cause some bradycardia, some sinus bradycardia, right? Okay, just know that for now. Then, guys, there is this other entity called sinus tachybrady syndrome, right? This is also called sick sinus syndrome. What is happening here, guys? We get, right? Again, nice P, nice QRS, the complexes are all nice, but the rate varies. So let's say I'm drawing only the QRSs, because it's easier for me. Let's say here it's like this. Then after a while, again, a long gap, right? Something like that. Then again, after a while, right? Rapidly, right? So like this, the rate is varying, right? This is called sick sinus syndrome, right? Varied RR intervals, right? What is happening here, guys? Here, now we don't know the exact mechanism as to why this is happening. This is a SA nodal dysfunction, but they have been correlated to certain conditions. One is, it is normally sometimes seen in aging individuals, right? Usually after the age of 60, 70, some individuals can show this. It's normal, nothing much to worry about. Sometimes there are some genetic mutations, guys. The undergraduate level not needed, right? There are some HCN4 genetic mutations, right? Not very important, right? Just remember some genetic mutations are there. Obstructive sleep apnea can cause this, right? Obstructive sleep apnea can cause this, and some neuromuscular junctional diseases also, right? So these kind of conditions can be related in this sinus bradykardia syndrome, or what we call sick sinus syndrome, right? Right. Then we come to the atrial arrhythmias. Now, any arrhythmia that is occurring above the level of that green level, above this green level, guys, above this green level, right? We call it a supraventricular arrhythmia. We call it a supraventricular. So basically, atrial arrhythmias are also, we call them supraventricular arrhythmias, right? Right. So let's take a look at this. How is this happening? What I want you all to understand, guys, normally, now in our sinus nodal arrhythmias, what happened? From the SA node, there was a rapid firing, right? That's why everything appeared normal in the ECG, just an increased rate. How did we see an increased rate? RR interval reduced, right? However, what is happening in this atrial tachyarrhythmias, if we are talking about the fast rates, right? What is happening is, guys, there is an abnormal focus. We call this, right? We call this an ectopic focus. Ectopic, right? Focus. We call this an ectopic focus. What is happening? This guy is also causing some depolarizations. He's also firing some depolarizations, right? So what is going to happen, guys? Depolarizations are now reaching the AV node from two different directions, right? Depolarizations are going to be coming, right? However, our AV node is special. This fellow, right? Our AV node, he can block whatever is unnecessary, and he can send through only the necessary impulses, and he will send. So let's say about 10. Now here, I don't know how many I have, 1, 2, 3, 4, 5, about 10. About 10 depolarizations came from both the SA node and the ectopic focus. However, right, only one is being transmitted, right? So if I draw this, what we will see multiple P waves, multiple nice P waves, right? And we'll see one QRS, one quick QRS. Then again, we'll see multiple P waves, right? And we'll see one QRS, right? This is what we are seeing, right? Now, this is the simplified version. What we often see is, guys, this P. Now, when the P is like this, can you identify where is the P wave and where is the T wave? Can you identify? Very difficult, very difficult. What is often happening is, guys, this P and T, they are overlapped, right? The P and T become overlapped, right? And this is what you see here, guys. Now here, I have put an image here. Here we get the P waves, which this is a P wave, right? That is a P wave. Here, this, let me draw it in yellow, right? Just after the QRS, we are getting a small T wave, but we are also getting multiple P waves and again another QRS, right? So here there is two P waves and a QRS. So the P and the T have gone over each other. This is now, I don't expect you all to, this is not really necessary, guys. For your undergraduate level, for MBBS, they will give you very clear-cut ECGs. They won't give you ECGs like this, right? But I just wanted to show you all that in atrial tachycardias, almost always P and T are almost unidentifiable. They are overlapping each other, right? Okay, right? So just remember that. Now, what you will get most of the time is this flutter and fibrillation. This you must know. This you must know. Tachycardias, right? The atrial one, right? Even if you forget, I don't really mind. Look at this. What is there to understand here, guys? What is happening? Now, previously we said there was one ectopic focus firing. In the case of flutter, guys, there is usually 2 or 3 ectopic foci, right? 2 or 3 ectopic foci, right? And they are all firing, right? Like this at their rates, right? When they are firing like this, usually, guys, in flutters, the firing rate is much high. It's about 250 to 350 impulses per minute. You'll see how rapid it is, right? In flutters, when there is 2 or 3 ectopic foci firing at the same time, right? Guys, can you all hear me? Or am I stuck? All good? Because, okay. When you all are not moving, I feel like you all are stuck. Okay, right? Okay. Right, so what is happening here, right? It's firing very rapidly, 250 to 350 per minute. This is not beats, not beats. We are talking about firing impulses, right? So what is going to happen is, guys, when you look at these rapid impulses, what did we say? The ECG machine, when it's detecting a rapid impulse, how is it going to? It's going to go very fast. Very fast, it will go up and come down, the ECG needle, right? So what is going to happen here? We are going to get these very fast, right, waves, which are the P waves. right? So they appear something like this, guys, right? These are what we call, this is the sawtooth appearance, or what we call the flutter waves, okay, right? Is everyone clear, right? These are not very difficult once you have understood the major stuff, right? Then, guys, now, so what do we see here? No well-defined P waves, right? Multiple small vectors that we see as flutters. We call this a sawtooth appearance. Remember that, right? But what do you also see here, guys? What do you think about the RR interval? RR interval is uniform, right? RR interval is stable. What does this tell you? No matter how much those rapid impulses are coming, AV node is like, no, you're not allowed to go, right? AV node, he will select only one fellow and pass it nicely down so that the ventricle will nicely depolarize, right? So the ventricular rate is still normal, right? Ventricular rhythm is normal. It's just that the atrial rhythm is abnormal. So you get the flutters. Okay, right? Right. Then we come to the next one, guys, the fibrillation. When we come to fibrillation, here the impulse rate is even higher. We usually say more than 350, right, per minute, right? Impulses are very rapid, right? So here, guys, how is this happening? If we take a look, there are multiple ectopic foci firing all over the place, firing in various directions, right? They're not even directed. The vectors aren't even directed properly, right? Going all over the place like this, right? Guys, can you all see the screen? Give me a second. Guys, let me. Wait, huh? Guys, can you hear me? You can hear and see me, right? Okay, let me share the screen again. Very sorry about this, right? Technology problems, guys. Right, wait. Give me a second, guys. Very sorry. Right. You can see the screen? All good? Yeah? Okay. Right. Look at this, guys. So this is what I drew. There are, when it comes to atrial fibrillation, multiple ectopic foci firing in various directions, right? Within the atrial myocardium, right? So they are going to give these tiny multiple small vectors in multiple directions. So the ECG, guys, if we draw the ECG here, right, it's just like slight oscillations, and there will be a QRS. Again, nothing, QRS, right? Slight oscillations, QRS, right? This is how the ECG is going to look, right? Because there is no definable P wave, no discernible P wave, right? Okay. So, now, what is another thing when you look at this ECG, guys? What strikes you when you take the ECG paper to your hand? True, we can see a atrial fibrillation pattern. There is no definable P waves, right? So there is QRS is still occurring. But what is one thing the moment you look at this ECG paper, what do you see? Come on, unmute and say anything about this pattern. Do you see any abnormality? I don't want you all to look closely, right? I see some of you are coming closer to the screen. No need. Just when you see this ECG, what do you see? Look at the baseline, guys. Is the baseline in a nice straight line? Is the baseline? No, right? The baseline here is going down, right? Here is going up, right? So the ECG baseline is varying, right? Even here within this one line, it is going like that, right? So the baseline, you see, it's coming like this, then coming like that, then again going up, right? This baseline variation is also seen in atrial fibrillations, right? This is the third point, right? So what do we see, right? One thing, it's a very fast rhythm, right? we will see because of the multiple foci firing, it's a very fast rhythm. There are no well-defined atrial vectors, so no well-defined P waves, right? So it's what we call the fibrillation waves, or what we call the simple F waves. Now the capital F is what, guys? Flutter. Capital F waves are flutter waves. Simple F waves, when you're reading books, if they have put simple F, it is fibrillation waves, right? And there is no proper baseline, right? So this is how it is. Now, usually, guys, in these, what do you see about the QRS here? About the RR interval, most of the time in early onset atrial fibrillations, guys, RR interval will tend to be equal, right? It will be stable. But after a while, what happens? This AV node. Now, what is the AV node doing? So many signals are coming, but AV node is like, no, you can't go. So after a while, what is happening? AV node is getting tired of this job. So this fellow gets weak over time. And what you see in this ECG, look at these RR intervals, guys. One is this much, one is longer, this one is a little bit long, this one is again short, right? RR intervals begin varying after the atrial fibrillation goes on for a little bit of time, right? Because the AV node starts malfunctioning as well. Okay, right? So this is what you can see in this ECG. Okay, right. Then we come to the junctional arrhythmias. Now, junctional arrhythmias here. Look at this. What do we mean by the junction? Remember that thick fibrous band that we drew in green at the start of the class, right? That is our fibrous area. That is our junction, right? In the junction, what do we have? Whom do we have? The AV node. Now, here, guys, we have to talk about what we call heart blocks, right? So to talk about heart blocks, look at this. I will stop the share. I will use the whiteboard, right? Look at this. Right. Okay. When we are talking about heart blocks, look at this, guys. Let's say here we have the atrium. Here we have the node, SA node. I will draw, the AV node. And here we have the ventricle. Now what has happened? Signals should come from the atrium to the AV node. And from the AV node, it must go to the ventricle, right? So let's take this AV node alone here. And we'll take a look at what is happening. This is the AV node, right? What is going to happen is, guys, in a normal person, you and I, right? What is happening? A signal comes from the atrium. There is a small delay in the AV node. That is what we see as the AV nodal delay or the PR segment. And then finally that will pass through. Correct? Right? Then let's say another signal came. There will be a slight delay that will pass through. Another signal came. Slight delay pass through. This is how it happens normally in you and I. Right? This is why we get the PR segment. Now let's suppose, right? Let me erase this. Say there was another patient, right? In him, right? The AV node. In him, guys, right? We get an impulse coming and the delay is very long. And then the impulse is transmitted to the ventricles, right? Ventricle. Another signal comes, delay is very long and then transmitted to the ventricles, right? Another one comes, very long delay transmitted. What is this? What is happening here? In the AV node, due to some problem, right? The AV delay is prolonged, right? Why is this happening, guys? Multiple causes. But what do I want you all to know? In the ECG, how are you going to see this? In the ECG, guys, you are going to see, right? One thing, this PR segment is prolonged. And if the PR segment is prolonged, what interval is also prolonged? From here to here, right? This is the PR interval. PR interval is also prolonged. Why? Because, guys, why are we saying the PR interval? Why don't we just say PR segment is prolonged? PR segment, what are we using it for? We are using the PR segment only as a comparison marker for our ST elevations. For everything else, we don't need the PR segment, right? What we are considering time-wise here, the PR interval, right? So the PR interval is prolonged through every beat, right? Through every beat, this PR interval is the same, right? Let's say, what is the, now you all know the normal PR interval, right? We have to have 3 to 5, right? 120 to 200. So this is more than that. And each of them, let's say this was X number of boxes. Here also X number of boxes. Same X number of boxes in all of the PR intervals. This is what we call a first degree heart block. This is a first degree heart block, a pathological increase in the PR interval, right? However, each P wave is followed by a QRS. Every P wave followed by a QRS. It's just that the PR interval is prolonged. Okay. This is first degree heart block. Okay. Then let's say we have another patient. When you look at this guy, right? Right? Or let's say that's the same patient. The same patient was there and you gave him some medication. Let's say you gave him a calcium channel blocker, right? Same patient, you gave him a calcium channel blocker. What is going to happen? 1P is coming. Again, the same patient, right? So he has a very long duration. The PR interval is prolonged and the impulse will be transmitted. The next one is coming. It's not transmitted. It's stopped. Again, another one is coming. That guy is transmitted. What is this, guys? Not all P waves are followed by a QRS. That is what I want you all to understand. Not all P waves are followed by a QRS. Okay, understood. So there are, in this patient's ECG, some P waves are there followed by a QRS. Then there is another P wave, nothing, no QRS, right? Nothing. Then another P wave, a QRS, right? Like this. So randomly in certain places, the QRS complexes are lost. This is a second degree heart block. Now, second degree heart blocks, there are two types. Let's go into that in a little bit. For now, just what I want you all to understand, when QRSs are dropped randomly, this is a second degree. This is a second degree. What was first degree? Just PR interval prolongation, right? Every P is there, every QRS is there. Here, there is PR interval prolongation as well. However, there is a drop of QRS, right? A drop of QRS. QRS is not there. Then, guys, we'll come to the specifics in a little bit. There's another situation. Let's say, right? Let's say there was a different patient, right? Or let's say, you can put the patient on adenosine or something. It's okay, right? There's a different patient, right? In this patient, what is happening, right? P wave coming, not transmitted. P wave coming, not transmitted. P wave coming, not transmitted. If all these P waves that are coming from the atrium come into the AV node and not transmitted beyond that point, how will the ventricle begin contracting, guys? How will the ventricle start its own impulses? The ventricle will start generating ectopic foci, like this. And those will generate impulses. Therefore, now P wave is the atrium from the SA node. There are impulses coming, but they are all being blocked at the AV node. And because of that, ventricle is not receiving any impulses. So he starts generating his own impulse. When this happens, what do you all think you will see in the ECG? P waves will be there. These guys, P waves will be there. And QRSs will also be there. Why? These guys are producing QRSs. But there is no relationship, right? Now, usually in a normal person, you and I, P should come first, followed by QRS, right? In this situation, one P will be here, QRS will be here, another P, another QRS, another P, QRS, again QRS, another P, like that, right? No relationship between the P and the QRS, right? However, right, based on how many ectopic foci are there, usually, guys, P waves are coming, right, at this rate. So the P waves will have a regular interval between them, and the QRS will also have a regular RR interval between them, right? But there is no relationship between these two, between the P and the QRS. This is what we call a third degree heart block. So what have we learned? We have learned a first degree heart block, which was just an increase in PR interval. We have learned a second degree heart block where QRSs are lost. And we have learned a third degree heart block where P waves are present, QRS is also present, but there is no relationship, right? These are the major 3 degrees of heart block, guys. Here, if we look at the second degree heart block more specifically, there are 2 subtypes. What are these 2 subtypes? Look at this. There are actually more than 2, but for undergraduate, right, 2 is enough. Look at this, guys. Firstly, if we look at the second degree heart blocks, right? We have one type of heart block, guys. Now you all can draw this, right? Something like this. I'm not drawing the T waves. T waves are there, okay? Right. Something like this, right? What do you all see here, guys? Look at this. Look at the PR intervals. First one is from here to here, PR interval, right? Second one is a little bit more longer, right? Third one is even more longer, right? Even more longer. PR intervals is progressively getting longer. And finally, right, somewhere here, there is only a P wave, no QRS. QRS is dropped. This is what we call a type 1 second degree heart failure. This is type 1, what we call Morbid's type 1. Morbid's type 1. This is also called Wenke back, guys. Wenke back, right? So what is happening? Long, prolonged drop, right? Prolonged drop. That is Wenke back, right? Okay. So Morbid's type 1, right? Then we have Morbid's type 2. Morbid's type 2, what is happening, guys? There is no prolonged drop. Just, right, PR is anyway long, and suddenly, right, this is the one we talked about in our example when we were talking before, right? Suddenly there is a loss of QRS. So there is only a PR prolongation and a sudden loss of QRS. Here, there is a progressive PR prolongation, right? Here is this much, then increase, then further increase, then drop. Okay, everyone understand the difference between Morbitz type 1 and Morbitz type 2, right? Give me a thumbs up, right? Okay, guys, are you all understanding today? I know today is a long session, right? I know it's a lot, right? Just bear with me, little bit more, right? Okay, then guys, once that is done, right, we will go to a specific syndrome, a junctional tachycardia, right? So these are the basic hard blocks that I want you all to know, right? Then we have a junctional tachycardia, guys. What is this junctional tachycardia? Very interesting one called WPW syndrome, right? Wolff-Parkinson, can you see me? Yeah. Okay, there we go. Wolff-Parkinson-White syndrome, right? What is this, guys? Here, look at this. Now, we know, right? Something like this. Septum is here, right? I will see the septum. What is going to happen, guys? From the AV node, we get impulses coming here to the, from the SA node, right? We get impulses coming here to the AV node, right? And then from there to the ventricle, right? We said this green area does not conduct any electricity, right? Okay. However, there are certain pathological conditions, guys, where there can be an accessory pathway, something like this, from the atria to the ventricle, something like this, a pathway, right? A pathway, right? Now, when there is an accessory pathway like this, these guys can transmit electricity. These guys can take electricity and come here, right? They can come here. And these accessory pathways, guys, they are very fast. They are very fast in conduction, right? They are very fast in conduction. So, from the SA node, signals are still coming in the usual way as well, right? Some of them are entering this accessory pathway and going around and coming to the ventricle, right? From the SA node, we still have the normal impulses also coming, right? So what is happening here, guys? If you look at the ECG, now this accessory pathway is doing what? It is bypassing the AV node, right? It is bypassing the AV node. If it is bypassing the AV node, will there be showing an AV delay or the PR segment in the ECG? Will you see? No. Why? This guy is bypassing. This is a rapid pathway that is bypassing the AV node. So you won't see the PR segment or the AV delay. So what is happening, guys? You will get the P wave. Immediately after the P wave, you will start the QRS, right? There won't be our usual delay before going to the QRS complex, right? Immediately after the P wave, this guy starts the QRS complex like this, right? So what are you seeing here, guys? What is this? This is the significant, like a tick, right? Like a tick, right? This is the significant finding of Wolff-Parkinson-White syndrome, right? Right? So you all have to identify this, right? When you all see an ECG. Okay, right? This is like an inverted tick, right? Because of the rapid conduction through this pathway, right? Everyone understood, right? This is also called, guys, AVRT, atrioventricular reentrant tachycardia. Why do we call it that? Now look at this, guys. Sometimes this patient, what can happen is, guys, these impulses are now coming like this. Now, usually these Wolff-Parkinson-White patients are normal. There is not really a big problem in them. However, if they take too much caffeine, if they take some drugs, right? If they take some recreational drugs, right? Certain medications also can, right? If something caused, right, an ectopic focus to appear in these Wolff-Parkinson-White patients, right? What is going to happen, guys? These signals will start coming into this accessory pathway. Now then, previously, what was it? Signals had to come all the way from the SA node to enter this pathway and come here, right? Now, if there is an ectopic focus, what is happening? These signals can quickly enter. They don't need to come all the way from the SA node. They quickly enter and come here, right? When they come here, guys, now these SA nodal impulses have still not reached this point, right? SA nodal impulses have still not reached this point. So this area is an excitable area, right? So what do? They come and they depolarize these areas going back upwards, and it forms like a reentrant circle, guys, right? What we call a reentrant circuit, right? Going in this, now here I drew it in the anti-clockwise direction because these areas are, they can depolarize these areas. It will start a reentrant circuit. If that happens, then it is dangerous, guys. These patients can go into atrial fibrillation, even ventricular arrhythmias, ventricular fibrillations, right? And they can even die. Right? So if we diagnose that a patient is having Wolff-Parkinson-White syndrome, if he's having an accessory pathway, even if he's not very symptomatic, we usually tend to treat him. What do? We burn this accessory pathway off, right? What we call ablation. We can do radio frequency ablation and we can burn this accessory pathway off and remove it off. Okay, right. That's about Wolff-Parkinson White, right? Then guys, right, about bundle branch blocks, right? Bundle branch blocks, right? Bundle branch blocks. Look at this. Very simple concept here. Now you all can go through these fast. Look at this. If I draw, right, something like this, the septum is here, right? It's the septum. In the middle is the septum, right? These are the two ventricles. Now we know what is happening. Here we have the AV node, right? And it is split into the left and the right bundle branches. And then we get the Purkinje system. What did we say, guys? In normal conditions, you and I, right? What is happening? Always in the septum, from the left to the right. Septal depolarization, always from the left to the right, right? We have already talked about this, right? Now look at this. So what is happening in a normal person? Always from the left to the right. Then this will depolarize like this. Left ventricle will depolarize like that. Right ventricle will depolarize like this. This is what usually happens in you and I. However, in certain conditions, now let's say there is a block, right? There is a block. Let's first talk about a right bundle branch block. Right bundle branch. This is the right bundle branch. Let's say there is a block here, right? The right bundle branch is blocked. What does that tell you? If the right bundle branch is blocked, all of this will not properly transmit any impulse. They will not transmit any impulse, right? So what will happen, guys? We are going to look at lead V1 and lead V6. We are going to look at lead V1 and V6, right? Okay. What is going to happen initially? Septal ventricular depolarization. The left bundle will still try to depolarize the right. Okay. So how are you going to see this initially, right? There is a positive depolarization wave coming towards V1, right? So we will see it as a positive deflection. What about V6? In V6, how will you see it? This is a depolarization wave going away from V6. So how will you see it? Negative deflection. Negative deflection. Okay, right? Then, now, when this guy tries to depolarize this right bundle branch, but the right bundle branch is blocked. Fine. He's like, okay, right bundle branch is not responding. Can't help. I tried to depolarize him. He wasn't listening. So I'm going to go ahead with my job. The left bundle branch will depolarize the leftover part of the left ventricle, right? The left bundle branch depolarizes the remainder of the left ventricle, right? How is this going to appear? Towards V6, what are we getting? Towards V6, we are getting a positive deflection. We will get a positive deflection here. Positive. From V1, what are we going to get? We are going to get a negative deflection here. Okay, right? Then what happens, guys? Now this entire side is depolarized. This entire left side is fully depolarized. If the entire left side is fully depolarized, what does it see? These fellows still haven't been depolarized, right? Why? This Purkinje system wasn't working. But what is the feature of cardiac myocytes? They have gap junctions. They have gap junctions. They can load cations, and now they will finally start depolarizing towards this direction, right? So what was the problem with the right bundle branch block? The right side of the heart is taking a little bit more time than usual to get depolarized. Okay. So now there will be a wave of depolarization coming in this direction. So what is that? Towards V1, right? We will have a positive deflection, right? And for V6, what are we going to have? A negative deflection, right? So in a right bundle branch block, now this was a right bundle branch block. In a right bundle branch block, what are we going to see in V1? An M-like pattern, right? What are we going to see in V6? A W-like pattern. Okay, right? So this is our marrow, guys, right? M-A-R-R-O-W. V1, we see M. V6, we see W. And R for right. R for right, right? Right bundle branch block. Okay, right? Understood? Clear? Lula, all good? I know today is tiring, right? Bear with me a little bit more, right? Okay, right? Then, guys, left bundle branch block. Very similar mechanism. In the left bundle branch block, what is happening, guys? Look at this. Right? This. In the left bundle branch block, what is happening? Right? We have, like this, we have a block here in the left bundle branch. So what is happening? None of this is able to, the Purkinje system is not functioning properly, right? Like that, right? Now, in this case, like in you and I, like in normal physiology, can this left bundle branch do the septal depolarization like this from left to right as in the normal condition? No. Excellent. Dulashi, right? Dulashi, right? Right. So Excellent. We cannot do it in the normal direction, right? If that is the case, guys, now the right bundle branch takes over. Right bundle branch will try to depolarize this fellow, right? He will try his best. So if we look at V1 and V6, now we are still looking at the V1 lead, which is somewhere here, and the V6 lead, which is somewhere here. When the initial septal depolarization now is occurring towards this side, if we look at V6, what are we going to see? A positive deflection, right? What are we going to see in V1? Negative deflection, right? Then what happens, guys? Right bundle branch tries to depolarize him, but nothing is going to work. So what is the right bundle branch? I tried, right? I can't help it. I'm going to depolarize my side, right? He will depolarize the right heart. He will depolarize the right ventricle side, right? If that is the case, how are we going to see this? V1 is going to see it as a positive deflection, right? V6 is going to see it as a negative deflection, right? Okay, right. Then we draw it like that because the right ventricle is much thinner than the left. You all know that, no, guys? Right ventricle is generally thinner than the left. So the depolarization wave is a little bit more, waveform drawn is a little bit more smaller, right? Right. Even this one is somewhere there. It ends somewhere there, right? Then this entire right ventricle gets fully depolarized. Now what happens? Same like before, he sees, all of these cells are remaining. Through the gap junctions, what will happen? Cationic loading, sodium channels open, all of that happen. And finally, the left heart will get depolarized. Finally, the left heart will get, when the left heart gets depolarized, you all know left heart is a thicker myocardium. In V6, right? What will you see? A large one like this, right? Large one like that, right? And in V1, you always see again a large one like this. Okay. What is this? This is our William, right? William. What is William? In V1, you get a W pattern. This is for left bundle branch block. And for V6, you get an M pattern. Did everyone understand this? Heart blocks, right? All clear? Right, right? We are here at the last one, guys. We are here at the last one. Ischemic heart. ECG changes in the ischemic heart. This is the last part for today. Look at this. Right now, this one, guys, you all already know majority of it. We've discussed this in the ischemic heart disease. So that's why I left it for the last, right? Because it's relatively easier than all of these other concepts, right? Let's take a look, right? Now, you all know there is something called an ST elevation and an ST depression. You all are all familiar with that. But we are going to take a look at why that is happening and how that is happening, right? Look at this, guys. Guys, can you all hear me? All good? Yeah? Okay. If we take a look at the ischemic heart, right? I'm telling you all, guys, if I take, this is the ventricle, right? I've taken the ventricular myocardium, right? And I'm telling you all, let's say there is some infarction or ischemia at this area, right? Okay. The basis of this ischemic ECG changes is something called the current of injury or the injury current. Now listen carefully, guys. It's very interesting, right? Look at this. If I take a look at this injured area, right? What do you all think? In an injured group of myocytes, do you think there are sodium channels, there are potassium channels, all of these are functioning normally in an ischemic, injured, infarcted area? No, these aren't functioning properly. So they are not opening and closing when we need it. They are opening, permeability is very high, they can allow whatever to come in and go out. So actually, if you look at these ischemic or infarcted regions, guys, they are always positively depolarized. These areas are always positively depolarized because their membrane permeability is very high, right? Okay, right? That's the first point I want you all to understand. Even at rest, these ischemic areas, right, are depolarized. They're fully depolarized, right? So what is going to happen, guys? Even when there is a resting membrane potential, now you all know the resting membrane potential is negative 90, minus 90, even when the rest of the heart is resting, right? This guy is depolarized. So what is going to happen, guys? There is a potential difference between the infarcted areas or the damaged areas and the normal heart musculation. So there is this current flowing, guys, outwards from this injured area, right? From the center of the injured area outwards, there is this flow of current, what we call the current of injury or the injury current. This is what is going to give us our ST elevations or ST depressions. We'll take a look at that, right? Did everyone understand? This is the basis of the ECG change, right? Now we'll go and see what is happening with this injury current. If I take this same myocardium, I will just extend it a little bit so that we get a clear picture. I've drawn this in your books, guys, right? The same thing, just I've extended for us to get a clear picture, and something like this, right? Right, like this. This is the same myocardium. I've just extended it a little, the drawing. Now let's imagine first, we have, now you all know two types of infarctions, guys. One is a transmural infarct. What is that? Full thickness, full thickness. What is the other one? We have a subendocardial infarct, right? Only in the endocardium. We have two. Let's take a look at both. If we look at a transmural infarct, what is this? This entire thickness is called, right? If I draw it like this, right? Entire thickness as an infarction or damage, right? Entire thickness, right? This is the transmural infarct. Whereas if you look at a subendocardial infarct, that is what we are going to talk about next, right? Right, same thing, same phenomenon, right? Like that, like this. A subendocardial is only here, guys, only here, right? Something like this, right? So you all can see here there is normal cells. There is normal cells. Here the full thickness is gone. Here the full thickness is gone. So I hope you all can see the difference between the subendocardial and the transmural. Now look at this. What did we say? Always the current of injury is from the center, the necrotic center outwards. Necrotic center outwards, right? So if I draw it here, it's going to be like this, this, right? This is the current of injury direction, right? Now let's say we have an ECG lead somewhere here looking at this injury site. This is an ECG lead. Same for this guy, looking at this guy, right? Look at this guy. Here, I will draw the current of injury here as well. In our subendocardial infarct, what do we have? Current of injury. There is some current of injury towards the, why? This area is normal tissue. This area is normal tissue, right? There is some current of injury all around this, right? Current of injury like this, right? Now, when this is the case, look at this. If we are going to draw the ECG pattern, look at this, guys. Here, the current of injury, is there any current of injury towards the ECG electrode? Is there any current in the this? Can you all hear me now? Yeah, better? Let me. Right? A second. Yeah, okay. Right? If there's an issue, just let me know. Huh? Thanks. Right? So what is happening here, guys? Right? Because this injury current, right, is not showing anything to this ECG lead, it is going to draw a negative deflection. Right? Then in that negative deflection, he will draw the P wave. That is atrial depolarization. Right? He will also draw the Q. Right? No problem. Right? The septal ventricular depolarization will be there. Right? And the R will come like this. Then, guys, you all know for the S, right, and the T. Now we are coming. What is going to happen here? When we are having, guys, the S, what is this? Basal ventricular depolarization. After the S, what do we get? We get repolarization of the heart, right? We get repolarization, which is the T wave, right? Soon after the S wave, now in a normal person, in you and I, soon after the S wave, before the T wave, what was this portion? This is the ST segment, right? ST segment. What does the ST segment represent, guys? The ST segment shows a period of time where the heart is fully depolarized. Therefore, it is not showing any reading, right? The ST segment, what did we say? This is a true isoelectric line, right? The heart is fully depolarized. Therefore, what is happening is, guys, right? This, soon after the S, right? The ST segment will be drawn along this true isoelectric line or the true baseline. Okay. And then we'll get the T, right? For the repolarization, it is going to come back to this negative and go like this. So what do we see as we get the ECG? As we get the ECG, what we see is, okay, ST has elevated. But what has happened? Actually, the entire tracing has come down except for the ST segment. Did everyone understand this? Right? Okay, this is what is actually happening in an ST elevation, right? right? The entire tracing comes down because this injury current is not showing in the transmural infarct. Injury current is not showing anything to the ECG level. This happens exactly the opposite in a subendocardial. What do I mean by subendocardial? Injury current is there continuously showing a positive depolarization to this ECG level. So continuously the ECG, the pointer is elevated, right? So if the baseline was here, the ECG machine is starting drawing somewhere here, right? Okay, same thing, same concept, but opposite, right? So here again, you get the P wave, you get the QRS, but again, when we come to the ST segment, that is the true isoelectric line, right? It comes down to the true isoelectric line, right? And then comes back up. This is what we see as a ST depression in a subendocardial infarct. Okay. Did everyone understand this? Right? Okay. If you all understood that, guys, right? One small part left, right? The ventricular tachycardias. Here, guys, nothing to explain. Look at this. If we take a look at ventricular tachycardias again, just like the atrium, how do these occur? Due to ectopic foci. Here, guys, what is happening? If I have the ventricle like this, right? You all know from the SA node, it must come to the AV node. From the AV node, the bundle of his, and then it must go. However, if there is an ectopic focus firing at its own will within the ventricle, what is this going to look like? This is what is our ventricular tachycardia. Look at this, guys. We will have the nice QRS, right? Nice PAV and QRS. Suddenly, this guy fires. Now, this guy, when he fires, do you think he will go through the septal ventricular depolarization, then major ventricular depolarization, then basal ventricular, like that step by step? No. He doesn't go through all of that trouble. He is somewhere in the corner, just firing at his own will. So the QRS coming from this ectopic focus, guys, it will look a little bit different, right? And then we again get a normal. These are all normal. This is normal. Suddenly we get a sudden weird QRS shape. This is what we call a ventricular premature beat, guys. Just like the name sounds. Don't get afraid of names. Ventricular premature beat arising from the ventricle due to an ectopic focus, right? Ventricular premature beat. Sometimes what do we get? We get, right, multiple ones like this, but they all look the same, huh? They all look the same, something like this, right? They all look the same because they're all coming from the same ectopic focus. They all look the same, right? This is what we call ventricular tachycardia. Now, right, there are different forms, guys. You always see various types of waves. Some will show something like this, right? Multiple, same type of wave, but multiple and a rapid rate. And then later, if you treat the patient, he will come back to normal, right? Okay, so this is our VTAC. This is our ventricular tachycardia, right? Okay, ventricular tachycardia, guys, if you don't treat it, right, very important, right, it will go into ventricular flutter, what we call ventricular flutter. And finally, it can go into ventricular fibrillations and flatline, right, if you don't treat. This is why it's very important. Ventricular arrhythmias are very dangerous, even more than atrial. Okay, right? So ventricular tachycardia can go to ventricular flutters, fibrillations. Next step is flatline. Okay, so you must manage it. Okay, right? That's about it. Okay, now look at this. I have put some ECGs, right? Now you all take some time, right? Not today, right? Now go and sleep, right? Depending on whatever time it is in your respective countries, right? Go and rest your brains a little. Right? I know today was a lot, guys, but I really wanted to teach this ECG section for you all. I know a lot of students are struggling with ECG, right? And it's very important, right? Very important for you all to understand. So that brings us to an end of this Asclepius series, right? About restreams, guys, still not confirmed, right? I'm trying my best. I will let you all know if it is possible, if it is doable here. Quite difficult, right? We'll see how it goes, right? I will let you all know in the group about these sessions if I'm able to restream. If I am, and if you're still in the second or third, fourth years, right? After about 2 weeks, just go through your notes, and wherever y'all are getting stuck, just watch the video again, right? Wherever y'all are getting stuck, right? Because I know today was a lot of concepts, but I hope you all understood ECG, guys. Now, when you all see an ECG, what should you all do first? Now, I have put in your last page. On your last page, guys, I have put a small description, when to order ECG and what to look at. When to order ECG, write these down. First thing, any patient coming with chest pain or palpitation. If you get any patient coming with chest pain or palpitation, you must order ECG, right? Dizziness, syncope, right? Sudden onset fainting, right? Any cause of falls, right? In an elderly patient, especially 60, 70-year-old patients, any cause of falls, you have to take an ECG. sudden onset shortness of breath, right? Can be acute heart failure. You want to look at the ECG, right? Strokes, TIAs, right? Last week we talked about strokes, right? You have to order ECG. Why? Why in strokes you should order ECG? Mitral stenosis might have been a cause, right? Mitral stenosis giving rise to clots that have gone up to the brain, right? So any of those you have to order a ECG, right? That is when to order. Then what do you want to look at? Now look at this, guys. I have put this, I think put a my NOPQRST. What is this N? You are looking for normal heart function. What are we looking for? What do I mean by normal heart function? Take the ECG immediately when you get it to your hand. Look at lead 2. Look at our rhythm strip. Look at the rhythm strip. Look at the rate and look at the rhythm. What do I mean by look at the rate? Check how many QRSs are there for how many large boxes, right? You all should know for 3 to 5 large boxes, there must be 1 QRS for it to be the normal rate, right? Then look at the rhythm. What do I mean by look at the rhythm? Check if each P wave is followed by a nice QRS. Each P wave must be followed by a nice QRS, right? That is our sinus rhythm. That is our sinus rhythm, right? Okay. So that is about the N. Then O for obvious features, guys. What do I mean by obvious? Now this is what I use, guys. This is how I look at ECG. Now in various books, you will find different things. What do I mean by obvious features? After looking at the rate and the rhythm, what I next look is, okay, I take a broad look. I look at the ECG like this. What abnormalities am I seeing here? Right? I don't look close. Right? Obvious feature. What are these? Write this down. Right? S, V, T, A, B, C. What am I looking here? Right? What is this S? Here, guys, I'm talking about ST elevations. ST elevations are obvious, no, guys. You all can see. Right? There are some tricky ST elevations, but for MBBS level, we don't usually get those for your exam. So ST elevations you all have to look for. Or ST depressions. ST depressions also. Right? Now, if there are any ST elevations or ST depressions, what is another important thing you should look at? Now, we know, guys, we look at V1, V2, V3, V4, V5, V6. We look at the chest leads to look for ST elevations. Always never forget to look 2, 3 AVF. 2, 3 AVF. What is our 2, 3 AVF? Where are they looking at? Right? Right? 1, 2, 3. This is AVF. What is our 2, 3 AVF looking at? Inferior surface of the heart. Inferior surface of the heart. So always when you're looking for ST elevations, true, you all have to look at all the chest leads, but also never forget 2, 3 AVF. Right? Then V. Always never miss a V-tach. Right? Never miss a ventricular tachycardia. This is what I got for my final MBBS here at Karapiki also. Right? This is what they gave me. Right? V-tach. Right? Never miss it. Never miss it. Right? Then here, guys, for the T, this is V-tach. V-tach together. Right? VT. Right? V-tach. Right? Okay. Then A. What is this? Atrial fibrillation. Never miss an atrial fibrillation. Right? What are you looking for in the atrial fibrillation or atrial flutter? Atrial flutter. Atrial flutter, we know the sawtooth. That is easy to identify. Fibrillation, right? There are no discernible P waves. And if you look at the baseline is going all over the place. Right? Baseline is going all over the place. Okay. Right? That is for A. Then, guys, what is this B? Look for bundle branch blocks. You all know William and Marrow. Right? I hope you all can memorize William and Marrow, but understand what is happening there. Okay? Understand. Right? Then for C, what is the C, guys? Look at the cardiac axis. Look at the cardiac axis. Okay? So this is about NO. Then we have P, Q, R, S, T. What is this P? What is this P? Look at the P wave. Look at the P wave morphology. Here, I don't want you all to focus on anything else. Just check if it is a broad bifid P wave. Just check if it is a broad bifid P wave. If not, nothing to worry about. Right? Q. What are you looking for Q? Deep Q waves. What is this deep Q waves, guys? Now, students who came to my ischemic heart disease, you all know what we call the pathologic Q wave, right? After an infarction, there is something called a pathologic Q. I hope you all remember. If not, go through that lecture. Okay? Right? So look for deep Q waves, right? Then R, right? Why did I put R and ST here again, guys? Always, before I hand in the ECG back, even in the hospital, I always check the rhythm one more time, right? Rhythm once more and ST segment once more, right? This is once more. This you have to repeat before you hand in the ECG, right? Make sure, if you all miss this, go on, right? In your exams, go on, right? You always have to come again to repeat. Real life also, patient will be gone, okay? Right? So don't miss these, look at these again, right? NOPQ is what you have to look for, right? And these two, look at again, right? That's all I have to teach you all about ECG, guys. That is your undergraduate MBBS level ECG. So we did 4 hours of ECG, right? Okay. 4 hours of ECG. But that's it. That's all you need to understand throughout your, until you are to, obviously when you all are going for your MDs and all, it's a little bit different, guys. There are lots of other things for ECG. This is the very basic ECG, right? Okay. Can I see some faces? Huh? How are you all? Are you all okay? Huh? Do you all want summer portion today? Right? The Sri Lankan students, you all know what that is. That's a nutrient supplement, Lula, right? It's a nutrient supplement here we use for pediatrics, right? Okay. Right. I know it was a lot, but I hope you all understood ECG rather than just memorizing, right? It will go a long way, guys. You all will know that, you all will understand this in the clinical setup, right? When you all come to the hospital to work, right? When you all see an ECG, when you all are able to think, this is probably this, you all give out your, ECG is not very easy, guys. Even consultant levels, there are certain ECGs. Now, this happened. So even when I was doing my internship, right? This is a little bit story time, just to relax your brains a little bit, right? During my internship back in Nanjing, right? There was a case. So the senior most professors, they weren't there on that day, right? They, you know, they go for the lunchtime and all, they go for a 1 hour break and they come back, right? So during that time, I'm still in the hospital and I'm with some interns doing something, right? At least touching a patient, looking at the auscultating, keeping the step, doing something. I'm always doing something, right? I know I'm bothering patients, but I do it, right? Right? That is how we used to do those days. So we had this one patient in the cardiology department, Renmin Hospital. Very interesting case. ECG, there were Chinese intern students also there, right? More senior to me also. They didn't see it. They didn't see what the pattern was there. There was something called a Brugada syndrome, guys. That is not very common, right? So I was able to identify that. And when the teacher came, the consultant came, I showed her the ECG and I asked, is this the case? And they were very impressed, right? The point is not to impress the teachers, but for you to get that, once you have understood, the moment you see an ECG, it comes to your head, right? I'm telling this with experience, right? Very easy to identify once you've understood what's going on. If you try to memorize VTAC is like this, right? The moment you see a VTAC that is something like this, you won't think that is VTAC, right? You will think that is P waves overlapping on T or something else. Okay. So you should not try to memorize ECG, never. Okay. So I hope you all gained something today, right? I hope you all gained something. Now there are students who came for all the sessions, right? Very thankful. I'm very glad that you all were here, right? So this Asclepius series was given, right, free of charge for a promotional thing, because guys, now I'm starting again teaching after like 2-3 years, right? We did this back in 2019, right? Once, and those students have now graduated. So I need new students to come and join, right? So if you all ask them, right, you all must be knowing your seniors, right? How we do things, right? You go through the A to Z in medicine, right? Not leaving anything out. The exam-centric approach, I want you all to know the difference, right? When you all are studying for exams, guys, if it is like 1 month before the exam, stop this kind of study, right? You all must, by all means, take past papers, go through only those, right? 1 month before the exam, that is how you have to study. Otherwise, pointless, no, guys. You all can fail exams by just studying this way, right? You all have to, for the exams, especially written type of exams, 1 month before the exam, only past papers, But rest of your medical life, don't waste the time. Study in depth properly. If you all are studying ECG, all of this must be there in your note. Okay, understood? Right? Don't try to memorize Marrow and William, right? When you're starting off ECG on day 1, right? That is just to pass exams, not anything beyond that. Okay, right? So I hope you all got some value out of this program, right? I will hopefully see you now next month. I'm a little bit busy, but I will continue to put some shorts on YouTube, some short videos, maybe 10-minute videos, something like that. After that, we will start some other programs coming up, right? I would love to do all of this free, guys, but you all know it's not sustainable, right? As I said, even purchasing Zoom is not cheap, right? Okay. So I hope to see you all again, right? I hope you all got something out of the program. If you all learned something new from me, right? My job is done. I'm really happy, right? So thank you for being here today, and today's session 4 hours. Thank you for being with me for 4 hours, right? I will see you all again, hopefully someday soon. Okay. That's it, guys. Study well, right? Take care. You're welcome. No problem.